patient with mainly with craving and some behavior issue, has got the approval from Saudi FDA, but the company failed to introduce it to the market, has long list of contraindication, mainly cardiovascular contraindications related to hypertension and cardiac disease. It has an effect of around 5 to 6% compared to the placebo, and again, more than 50% of subjects who enrolled on the data of this medication has lost more than 5%. Phentermine, which as I mentioned earlier was the first medication that approved for obesity in the globe. It's a sympathomimetic drug, is not available in the Saudi market. We have an experience in KFMC with this medication, was available for some time with a special request. Very good medication that works in, as a sympathomimetic agent, and but it has a long list of contraindication and need to be used very carefully. It's a controlled medication, so it's approved only for 3-month use, short-term use, up to 12 weeks. And here is the effect on a Korean study has looked about the effect at 12 weeks and the safety and the risk of addiction with this medication. Actually, there was no risk of addiction, and the weight loss was around 7%. So here, if you look about the effect of the phentermine, you can see that patients who use this medication compared to placebo, they reach up to 8% weight loss compared to the placebo. Combination of the phentermine with topramate is called casemia, is a medication available in US and some European countries, not available in our region, so we'll not go in details of this for the sake of time. Here is just a comparison between different anti-obesity medication, looking to the effect of each one of them. And if you look to that, you find that every arm where the phentermine is, it will be the winner. So phentermine is a really good medication, followed by GLP-1 liraglutide 3 milligram. So semaglutide 2.4, this is a medication that we are waiting for. I think it's in the process of getting the approval from the Saudi FDA. It's not available in our market yet. We have the semaglutide 1 milligram, which is the Ozempic, that's approved for type 2 diabetes, but it's not for obesity. Again, it's a long-acting human GLP-1, achieved really promising results.
2 minutes.
2 minutes, okay, for obesity more than 15%, and this is the categorical weight loss. Significant improvement in metabolic risk factor. So this is a medication that everyone is talking about, which is the tirzepatide Mounjaro. This medication hasn't been approved for obesity anywhere in the globe, but it's expected to get the approval in a few months from now. Again, it's a combination of GLP and GIP-1, once weekly medication, achieving something around 20% weight loss, which is that result that's similar to the bariatric surgery. And this is why people of the surgery started to get worried about this medication. So it's a very promising drug if you look to the data, but still we don't have this in the real world evidence. We will see what will happen when we use it in the clinical scenario. So what's emerging pharmacotherapy in the future? We have the step up for the semaglutide. They are studying the semaglutide at 7.2 milligram. We expected to have the result, the early or preliminary data of this trial in next year. We have the CagriSema, which is almost in the phase 3 trial. Very promising drug, more than 20% weight loss is expected with this medication. We have the Amgen drug, which is AMG 133, that's still in phase 1 trial, hasn't been got the name yet. It's a once monthly injection. We expected the results almost still in phase 1, so maybe take 3 to 5 years to have the results. It's once monthly injection that produce more than 20% weight loss. And we have the big gun, which is the triple agonist. We are probably will get the result of this trial in 2 years from now. This is a triple agonist between GLP, GIP, and glucagon. The expected weight loss is 35%. So there is also the oral semaglutide and other medication that's also coming in the pipeline for the obesity management. So this is a huge topic that can't be covered in 15 minutes. So we'll just try to summarize the clinical approach or the tips that it can be used to treat patient with pharmacotherapy. It's very important to counsel the patient honestly about the side effect, comorbidities, looking to the comorbidities, making sure that the patient is candidate for medical therapy, choosing the best agent, especially in relation to the price and side effect and complication, monitoring the follow-up. How long should pharmacotherapy be used? Obesity is a chronic relapsing disease, so once patient respond, they need to use the medication for life. So this is a key recommendation, or in summary, we recommend starting pharmacological treatment in combination with lifestyle as per the guideline. And if the patient did not achieve the 5% weight loss, so moving to another agent or another option for obesity management is advisable. Patient with class 3 obesity should be referred to a multidisciplinary team. And we recommend that all internationally available medication to be licensed in Saudi Arabia, as we are limited to few medication. We recommend that pharmacological therapy should be reimbursed by health insurance, as it is difficult to attain and maintain weight reduction with lifestyle medication only. So just final conclusion, pharmacotherapy combined with lifestyle will increase the proportion of people that respond, magnitude of response and duration of response. It increases the magnitude of the weight loss to help to improve the risk factors and complication. Obesity is chronic disease, need long-term follow-up and management. Thank you.
Thank you, Dr. Abdullah, for your nice presentation. We'll keep the questions in the end, Dr. Khalid. Now we will invite Dr. Mishal Agil to present Overcoming Psychological Barrier in Obesity Management. He's a consultant psychiatrist, associate professor, mood of anxiety disorder, congenital behavior therapy. Please, for your...
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. صباح الخير. It's my pleasure to be with you today, and also I would like to thank the organizer and scientific committee. In the next 15 minutes, I will just highlight some of the psychological barriers in obesity and how to manage some of them. Any healthcare provider working with people with obesity, he might have some of those questions. Why don't many individuals seek medical advice for their obesity? And actually, what is their perceptions toward their obesity and the management of weight reduction? And also, for those individuals who start the treatment and management, why some continue the treatment and intervention and others are not? Many studies actually looked after those questions, and the finding in those studies, there is a cognitive process and has an important role in the management of obesity. Also, maintaining unhealthy eating habits and changing it to healthier habits is not that easy due to many psychological and social factors. And there is many recommendations from different studies that there should be a greater focus on quality of life factors in weight management programs such as psychological, emotional, and social well-being. And those actually factors important in the initiation of the management and in maintaining and adherence. Many individuals with obesity experience distress, and this because of blaming themselves of having excessive weight, especially if they tried before to decrease their weight and they failed. And this distress actually increased if they perceive themselves to have poorer health in general because of obesity-related medical conditions such as chronic pain, arthritis, and cardiovascular. The association between the cognitive factors and there is many association between the cognitive factors and treatment discontinuation of weight reduction, the amount of the weight decrease, and also the adherence long-term on those managements. This is actually reached to the conclusion that we need to understand the patient perceptions generally and individually. In general, actually, in any patient would like to change his behavior in general in obesity and other in eating habits or any other behavior, there is 5 stages. We have to identify our patient in which stage he's on: the pre-contemplation, contemplation, preparation, action, and maintenance. And with each patient, we have to identify in which stage he is. The pre-contemplation, that when the patient actually not aware about his condition, not aware about the risk. He's happy with having this excessive weight despite the medical problems that he's having. The contemplation, that he knows, but actually he don't have any plan for the weight reduction. In this, actually, we can categorize those in pre-contemplation in three zones. The green zone, that we can push the patient directly to the intervention, the behavioral modification or other treatment. In the yellow zone, actually, when he's hesitant, actually we start the behavioral changes with discussion. And whenever he's in the red zone, when he's not ready and not convinced, we continue the discussion and the motivational interviews. There is actually many ways when the patient is in the yellow zone. One of the things, as a healthcare providers, we have to understand that having ambivalence regarding changing weight in our patient, it's normal to have it. And it's many times, it's not going away from the beginning. Actually, with continuation of the intervention, things started to be changed. And also, there is always be cons of continuing having those with weight gain, but actually we have to discuss and to weight it with the negatives. There is actually two areas in the brain responsible for behavioral changes, the frontal and the limbic system. The frontal depend on the decisions of the logical decisions. The limbic depend on the pleasurable activities. And this is the problem when we are dealing with the limbic system. The healthy behaviors is abnormal behavior for the patient because he used to get because actually whenever we start to advise him to change his medication, to change his behavior, this is actually, it's an abnormal behavior to him. He's not getting used to it. And also it will affect his pleasure. He will face resistance, and he will consider the short-term gain than the long-term. Also, there is environmental factors that pull the patient to the unhealthy behaviors, the invitation, social gatherings, and many things, especially with the good restaurants now in Riyadh. This is actually in a study, a multicentric study in Italian. It's done by the Italian National Health Services. They include around 2,000 patients with the different interventions, surgery, diet, and medications. 51 of those actually interrupted their treatment by 12 months. The main predictor factors for this, lower in age and higher in expectations. Also, those with a primary goal when they focus more on their experience, on their appearance. Those are actually the predictor factors of non-adherence to the intervention. And the strongest predictor of adherence is actually lower expectation of weight loss in the first year. This is actually a study that I'm sure that many of you are familiar with it. It's a multi-center study in different countries. They started, in this study, they would like to know the perception and compare it between the patient and the healthcare providers. For those actually feeling that they are responsible about their weight gain from the patient perspective is 81, from the healthcare provider 30%. And this high percentage of having the responsibility while it's disease, it's most likely come from the pressures, the stigma from the family and the family comment. When they ask the patient, do you believe that you are able to lose the weight? 85% they mentioned that they able to do so, while actually the healthcare provider, half of them, they said no. Also, 62% actually, they identified that they could lose weight if they set their mind. But unfortunately, not all of them started this. Why? The question is actually, there is many psychological reasons. Fear of failure. Some of personalities, they don't like to start something without guaranteeing that they will succeed. Also, previous failures of weight reduction, procrastination, and also setting priorities. He not putting it as a prior in his actually do list. Also social and work stress. Here if we go to the, this percentage, 71% of healthcare provider with the green one, they felt that the patient is not interested in losing weight. With the same dose patients, only 7 they are mentioning they are not interested. Many of the healthcare provider in family physician sitting, actually in the screening, they avoid to open the subject of obesity when they are sitting with an obese patient. Why? Some of them maybe not interested, maybe lack of knowledge and information, maybe not aware about the importance of this, and also some of them fear of dealing with negative emotions that he might trigger his upset or something like this. While from that study, they noticed 68 from people with obesity, they liked to open the subject during their interview, and 64 having positive emotions, despite 44 of them having actually negative emotions when they talk about their weight, excessive weight. We must be careful when we're discussing. There is a big difference. When I advise the patient, you have to decrease your weight, why you didn't decrease your weight, why you are not doing things to decrease your weight, compared to, do you think about decreasing weight, is it important? Would you consider this? Do you have actually the options that you have, that we have to help you in decreasing their weight? This is actually a quote from one of the obese patient. She mentioned that when I come back from the doctor, I eat more because of the depression, and I felt bad about myself. This is why we have to be cautious when discussing the weight reduction with our patient.
2 minutes.
2 minutes. Okay, that means I have to skip some of the slides. Actually, in the interview, we have to be skillful in motivational communication skills and not to be judgmental, to empathize with the patient. This is actually the general advice. This is one of the tools that we might use in actually what is the pros and cons of staying without decreasing the weight, or to start one of the weight management interventions. We have to also identify those in general causes. There is an individual cause with the coping mechanism when the food is one or eating one of those. Also the blame and shame from the family, how the patient or to deal with those blames, and also how to minimize it while discussing this with the family. To include the psychological intervention in actually the management program. Also to have the general, how to actually minimize the general social stigma in the community. In summary, it is actually expected that people is not adherent or there are high prevalence of non-adherence. This is actually to decrease or minimize the frustration that we have in our clinic when dealing with our patient. Also, cognitive reasons of non-adherence are common. Communication skills is important, actually. Also, minimal intervention might make big changes. The take-home message: we have to avoid. We should avoid the self-blame, and to minimize the self-blame that the patient has, to eradicate the misconception that the patient are not motivated. Usually, there is something we call it rationalization as a defense mechanism. Whenever actually we would like to avoid talking about subjects, we might accuse the person in front of us that he is not interested. To find the real reason behind the previous unsuccessful experience or failure, so the psychological and cognitive factors important in short and long-term weight management. Thank you.
Thank you, Dr. Mishal. Thank you, Dr. Mishagil. Very informative topic. We will keep the question in the end of the session. Thank you. The next presenter will invite Prof. Abdulaziz Al-Uthman, lifestyle intervention. This is an important topic before any other intervention. Thank you for joining us. It's our pleasure to be with us. Thank you.
Thank you. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. سعد الله صباحكم بالخير. Thank you for inviting me actually, and I apologize not being with you yesterday, and thank you for giving me the opportunity to be today with you. I will just give you just a brief about the lifestyle intervention. Lifestyle medicine is not just theory. Now it's evidence-based practice of evidence-based medicine. I will give you just as you know, there is a lot of chronic diseases, a high incidence of chronic diseases in Saudi Arabia. Unfortunately, with a high quality of health services to these diseases, still the incidence is increasing. So we have to find a way to manage these diseases. One of them is to start with prevention. And one of the approach that I used 25 years ago now is the lifestyle modification and lifestyle medicine. And lifestyle medicine is having five pillars. One of them is balanced diet. Means not healthy diet, but balanced diet is okay. Then physical activity. We don't use the word exercise even for the patients. We try to use physical exercise to encourage all people to walk or to do any exercise at home. Stopping tobacco and alcohol, stress management. You need actually to avoid any people or negative people or those will not helping you actually to either to lose weight if you are obese or to control your glycemic if you have diabetes, and also controlling our quality of sleeping of between 10 to 4. Very important actually in releasing of many hormones, as you know, growth hormones and melatonin and other hormones. And also positive, good relations with others. We didn't think that this is having important, but now many studies focus on this. With good relation with you deal with positive people, even in the health providers, when they encourage you, as Dr. Abdurrahman said, encourage your patients and give them the hope that they will be better in health, not only in losing weight. For example, for obese people, we don't focus only in obesity, but we try actually to say we'd like actually to improve your health in general. So these 5 principles is very important actually to get them together and to deal with your patient at general, not only depending on anthropometric measurements. Despite we have a very big problem in assessment. I find many hospitals, they don't do the NCP or don't do the right assessment according to the guidelines. They just depend on height and weight and body mass index, which is not enough. Wellness, these are the main things we need to do. I mean, my message is not for those having chronic diseases, but my message for me and for you, we should start to improve our lifestyle. Even this lifestyle should be gradually. We don't need to change everything in 1 day or 2 months or 3 months. All what we need actually to improve our physical activity, to use stairs, to park our car a little bit away, to go to the farm mosque, we need to visit our friends, also to introduce vegetables, fruits, to train our kids actually to use this or to eat these fruits and vegetables because they don't like it. Why kids, they don't like healthy foods? Because 2 things. The first one, they don't introduce to the healthy foods when they are younger, 1 or 2 years. 2, when they eat too much sugar, they don't like the healthy foods because as much as they eat more sugars, they will hate non-sugary foods. And also mental approach, as Dr. Abdurrahman said, very important actually to give them, to be optimistic, to help patients to find a way to control or to improve their lifestyle. Lifestyle and mindset. Very important also is to not find the goal, to say, okay, my patient weight is 100, so you should reach 70. This is not good. This will not help the patients to lose weight, but give him or her very short, target to do. Not important actually to reach the ideal body weight. And also healthy eating habits. We need actually to introduce it. I just talked a few days ago about المعايدات. In some hospitals, unfortunately, in some schools, despite with the Eid celebration, they give the kids or children or even the hospitals many sweets. Now we are talking about need to avoid this. Why should we bring it in our parties? We should actually find a way to have healthy alternative foods. Healthy lifestyle is not food, is not diet, is not exercise. It is the whole life. For yourself, for your family, for your community, for your department in your hospital, for your clinic. Try to exercise it, because this will give you the power actually even to convince your patient to do this. Enjoying meals. We don't enjoy meals. We are eating fast because we are depending on the fast foods. So we need actually to enjoy meals. If somebody knows me, I'm against dieting. I don't give my patients diet. Diet can be, restricted to in hospitals and some patients and under control of dietitians and physicians. But in general, no dieting. Try to enjoy your life, your foods, but control it. These are some diseases, proved that lifestyle medicine help actually to control these diseases. Obesity, stroke, diabetes, cancer, some cancers. By the way, we have too many lifestyle medicine here in Saudi Arabia, one of them in King Fahd Medical City, one of them the Prince Sultan Medical Military Hospital, and different hospitals. Now we are trying to helping or encourage health professionals, physicians to do or to introduce lifestyle medicine within their clinic. These are some benefits or health situations can be improved by health life or lifestyle medicine, and we will publish some studies soon, inshallah. Do we have a procedure and assessment? No. Diagnosis and treatment? Yes. There are some procedures and pathways. Unfortunately, no, we don't have clear guidelines here in Saudi, but now there is a procedure or pathways can be used by using these 6 pillars of lifestyle medicine in our clinic. Also, you need actually to be trained and work as a team. The patient should be referred to the dietitians, physicians, bariatric surgeons, even psychologists. We should work together actually to achieve our goals. There is something called the personalized. All the time we are emphasis on personalize your assessment, personalize your diagnosis, personalize your treatment. Nothing can fit for all. But also in lifestyle medicine, should be personalized, and even the new guidelines for assessment, you should write the lifestyle or family lifestyle. There is no food suitable for all. Don't make even your kids like the foods that you like. Give them the chance to choose their foods, since it is balanced. If I just take an example of lifestyle medicine in diabetes, you can see how we can achieve by doing lifestyle medicine. Yes, we should have the evidence-based medicine in choosing the right diet, by portions, by the healthy plate. These are the healthy plate, not for obese people, but for diabetes. We have 2 different healthy plates designed for each disease. And also using carbohydrate counting, glycemic index. I know there is too many people, they are not aware about glycemic index and diabetes. And I intend to give this slide to show, what do you think? For example, watermelon, is it suitable? Is it suitable for diabetes? Is the glycemic index is high or medium or low? Watermelon? Let's start, sorry, grapes is glycemic index is low, so suitable for diabetes. Bananas is low. Honey, it's honey, it's medium. White rice is, our sugar is high. White rice is medium. Raisins is medium. Watermelon is high. You should not give watermelon for your diabetic patients. Popcorn, despite it has low sugar, but actually the glycemic index is high. Potato chips is okay. Pizza from wholemeal is also okay. Ice cream with milk is medium glycemic index. Spaghetti is okay for patients. So we need actually to combine all of this. Should be considered glycemic index with your management. So you need actually to when your patient come to you, either obese or diabetic, you need to assess the whole family, because to correct the lifestyle of one person, you need to correct all the whole family that will help this patient or the person to fulfill the requirements. Quality of life is very important. We don't focus on diet or programs. We need actually to improve the quality of life, make them enjoying this. Simplify your life. We didn't actually to eat too many things in our party or on our foods. We need to focus on the few foods that will help to control these diseases. Start gradual with the patient. Give them the hope to start just a step by step that will help actually your patient to achieve their goals. If you give them very hard goals, they will not be able actually to do it. Alhamdulillah, we have lifestyle medicine conference starting inshallah next Monday. أمير حايل يفتتح open this ceremony ويفتتح في الصحراء. We are actually having also some activities in this lifestyle medicine conference, and also we have certification for those interested to have lifestyle medicine. We have some activities with the scientific program that we have in the morning. We give lectures in different areas, and we have some activities. We actually encourage all of you, to use lifestyle medicine in treating chronic disease. Thank you very much.
Dr. Abdulaziz, can you sit just to get a few questions before to shift to other? Dr. Ali, Dr. Ali, if you can. Dr. Khalid. Dr. Ali, if you can come. Have a seat. Any question to the speaker, please, before we shift to the second session?
السلام عليكم. يعطيك العافية بروف عبد العزيز. بخصوص if I would like to see if there is any obligation for the clinical pathway in our patient for bariatric surgery, that it should be implemented there. I found in our practice people resist to come to the psychologist and to do this modification for the lifestyle. Is there any advice from your perspective that how we can attract our patient so that they can do really or start with this lifestyle modification even pre-op, as this is the only will continue with them post-op with the good outcome? Because unfortunately the weight regain and these things, because of the bad habit, they did not change it pre-op, it will continue with them after that.
Thank you very much. This is very important question. Actually, who's responsible about this? We make it difficult for our patients. We tend to give them diet, eat an apple in the morning and eat banana in the afternoon, which is wrong. So even the diabetic patient, they regret, they resist to go to the clinic because they find, they have the symptoms, and they know maybe they have diabetic, but they didn't go to the physician because they said, because the physician will give a kursan, jarish, no bread, no rice, which is wrong. Wrong. I give my patients rice, bread, everything. Even I told my patients, and even I teach the family medicine, don't say diabetic diet between us. But for your patient, don't say diet. What is the characteristic of diabetic diet or obesity diet? Say diabetic diet. It is low sugar, low salt, vegetables, fruits, fluids, balance. This is the healthy diet. So we make it complicated. So for this reason, they don't want to go. They don't want to change because they think we as dietitians, it's our mistake, will give them an apple in the morning. And so we need actually to educate our patients, to simplify it, to use the social media as much as we can, to spread our message, to simplify the diet, simplify our message, and we need to go work together as a team. I feel proud that I'm a member of different bariatric surgery and diabetic associations. Very important to work together. This will help our patients, but very important also to start with ourselves.
بس لو تسمح لي دكتور, something just to add. This is actually from the nutritional dietitian perspective. Regarding actually the psychologist, I think we have to review our psychologists that work in the clinic. Sometimes the qualifications and the qualified person that's sitting with a good experience in dealing with the obesity and bariatric surgery complication after surgery, it is important. Usually, actually, the patient, they can evaluate ourselves when they are sitting with someone telling them something they are new about and something they are familiar about without giving specific strategies. I think the problem with us, many of the programs, actually, they recruit junior psychologists. They have no experience with dealing with such cases, and it's end up that the appointments actually not attractive to the patients.
بس اوضح شيء, ان شاء الله قريبا we'll have guidelines for bariatric surgery and we finish
Michelle,
this.
if you can join
it
us,
needs to
please.
approved. One of the guidelines to train the patient before on pre-surgery, to give them the training how he will do what he or she will do after surgery. So guidelines, inshallah, will be published soon, inshallah.
Any other question, please, to the speakers?
Assalamu alaikum. My name is Dr. Hassan Mikbel. Actually, I'm a diabetic patient. And my question is for Dr. Abdulaziz. Thank you so much for your interesting presentation. You presented one interesting slide, which is some examples for low glycemic index and high glycemic index. Actually, I have been diabetic patient for 15 years. What I know that stay away from grape and banana. And the interesting thing that you just presented the opposite, that grape and banana is low glycemic index, so it's good for diabetic patient to have. My question is, why is that? We have a lot of conflict. Many dietitians said stay away from banana, and some other dietitian will say banana is good for diabetic patients. So how can we convince our diabetic patient regarding these fruits?
Thank you for raising this point. I need actually to say that we should combine carbohydrate counting with glycemic index. Some foods that having high glycemic index but low sugar, and some of them having high sugar, for example, the popcorn, low sugar with high glycemic index. So we should combine them. I'm not saying to eat bananas all the time. I need to join carbohydrate counting and glycemic index. For example, watermelon. Some people they eat it. They think that it's okay to eat it because it's having fibers and fluids, and not the case. So we need actually to correct all of this. But by the way, I'm retired or resigned. I'm free for all centers. For free. أنا قعدت تقاعد مبكر، تفرغت عمل تطوعي مع أي مركز. أنا عمل تطوعي مع اي مركز يحتاج من مراكز وزاره الصحه لاي خدمات او شيء في الفري. ترى يعني انا
جزاك الله
يعني
خير، بارك الله فيك.
ما عندي مشكله، أنا متبرع ومتطوع لهذا الشيء وانا مستفيد.
شكرا، بارك الله فيك بروف. ان شاء الله we'll have a lot of communication with you. The thing how we can implement lifestyle modification, you mentioned some points, but how to mention at the level of ministry, how we can, this is very important part of management of obesity and other diseases.
In the first conference that in Hail 2 years ago, some of the audience is not feel that lifestyle medicine can change all of this. Some of them now, they are speakers with us next week. So actually we need to invite all of you to join and to read and to know about lifestyle medicine. This is the first. The second thing, we need actually to publish our work and to work with the different centers and to offer our experience to the centers. Then we need to evaluate it. So we can train some health providers with short course in Ministry of Health. Then introduce this within the services.
Why would not to work at the level of primary health care? Because the first line and they will pick up these patients. Maybe we cannot see these patients. They will not come to all hospitals. But I think we should. I would recommend in the end of this conference to mention your name to the Ministry of Health, to Dr. Abdullah Sahimi, to involve you in this program, and we will be happy to.
I'm ready. I'm صراحة supporting the community medicine لأني مقتنع من هو أدرس الزمالة to primary care to start with. Yes, and I can help anytime.
We will keep it as one of the recommendation point. Thank you very much for it. Dr. Ali, I have a question because I have to go to the second session. Dr. Ali Shehri, thank you for joining us here in this session. Tell me in brief the role of medication or obesity medicine after bariatric surgery, and at what level we need to refer the patient to you.
Thank you, Dr. Bukhatar, for the invitation, and thank you for the organizing committee. So the role of the let's say obesity drugs or obesity pharmacotherapy in the treatment of the obesity in general, the new era in the treatment of the obesity is combination of both medical and surgical treatment. The role of these drugs post-bariatric surgery is very important. As you know, the prevalence of the weight regain post-bariatric surgery in our community is very high, touching, I think, in some data about 50%. They struggle with weight regain post-bariatric surgery. So the role of the medication post-bariatric surgery is indicated in patient with weight regain or in a patient with suboptimal weight loss post-bariatric surgery. So any patient who did not achieve the expected, I will not say the desired, but the expected weight loss post-bariatric surgery will be indicated to started an anti-obesity medication. And again, the patient who is having weight regain.
A period when
so the period is not recommended to start the obesity medication at least 1 year post-bariatric surgery, because the pathophysiology and the hormonal changes that happen due to the bariatric surgery is still ongoing. So the recommendation says 18-month post-bariatric surgery, you can start the medication. And you have to be careful, especially with the patient with using the GLP drugs, because patient who did the bariatric surgery, the internal GLP is already high.
So we have to hold them.
Yeah, so if you give them the GLP earlier, you might induce pancreatitis or induce other complication of GLP. So I think 12 to 18 months is the recommended period,
Great.
especially for the patient who has suboptimal weight loss. Patient with weight regain, definitely they will be passing this period.
Thank you for this excellent information. Last question for you, Doctor. Dr. Mishal, thank you for joining us today in this conference. You mentioned a very important point that psychologists who's in the bariatric center, majority of them, they have no experience of obesity. Now, how we can, do some rehabilitation for them? And this is one of the recommendations also I want to add it to Dr. Abdullah Sahimi, so we can, he's the I mean, director of all specialized center in Ministry of Health, and he's very supportive for this point. We have a lot of psychologists, but they are not trained. They are just seeing the patient, but they are not seeing in a proper way. So we have around 25 centers in Ministry of Health. We always say we need a psychologist in every center, but they are doing their work in the proper way? I cannot say all of them, but how we can rehabilitate courses, or what do you think is the best for them? Thank you.
Thank you for raising this actually important point, Doctor. Actually, one of the things, when we see regarding the physicians, when we start actually to be in an organization, they actually allow us to enter a board program for 4 years. Actually, not having programs, this is one, and this is from Saudi Council. Not having even other postgrad or diplomas in the universities in this aspect, this other aspect. The other thing, to consider at the beginning of the recruitment that I'm recruiting someone without previous experience in this aspect, and he should or she should get involved in one of those programs, and those actually with the collaboration between Ministry of Health and Ministry of Education, and also with the Saudi Council, to establish such programs for those actually in this area. We know that the centers of excellence should consider psychological interventions. Sometimes, many times actually, those centers only recruit psychologists to fill the requirements rather than to provide the services. Thank you.
Thanks a lot for this information. Okay, we have one question, Doctor, please.
Yeah, thank you, Dr. Bukhater, for this session. I actually like the combination of this session. Psychological matters with lifestyle, really, with the judging to go to surgery or medical treatment with the patient, in the patient mind's decision. I'm Dr. Faiz from Bisha. Actually, we have a rule there in Bisha that any bariatric patient, he want to go for surgery, he should decrease 10% of his weight before going to the surgery. We don't have a line, standing line for patient, like you will be after 6 months, you will be after 1 year. No, actually, we are saying, for example, patient, he is 150 kilogram. If you want to go to surgery, decrease 15 kilos from your weight, then I will proceed with surgery directly without any line. If he decreased this 15 kilos, I'm sure that he has the perfect psychological matter with the perfect lifestyle that he can go up to. In this way, we have a lot of patients number. The number of moderate to severe anxiety, it is approximately 0. Mild depression, a temporary mild depression we have. Even the prescription of escitalopram, it is very low with us. The referring to the psychiatrist clinic, it is very low with us, alhamdulillah. Only few of cases out of large number of patients. Actually, I have some questions here for Dr. Mish'al and Prof. Uthman and also Dr. Khalid. Dr. Mish'al, can we go up to the patient's mind to convince them to decrease weight up to 15, 20 kilos and let them proceed without hypnotizing them, of course? And we are conducting a study in Bisha that if patient lose more than 10% of his weight prior to operation, then the psychiatrist illness post-op, it will be near to 0. We are still conducting this study. For Prophet Uthman, do we have any Arabic textbook to giving the patient prior to operation that they can help them in the lifestyle? And for Dr. Khalid, I hope really this medical treatment will work out. It will help the surgery by any means. Thank you so much for this fantastic session.
Thank you. In brief, but in general, actually, maybe if you allow me to disagree with you, putting only one parameters of decreasing 10 kgs is actually maybe unfair to many patients. The point actually, the doctor or the team would like to just make sure that the patient might change his behavior, and he's able to change his behavior. This can be done by the assessment rather than actually having it as a parameters, because even sometimes with changing those behaviors, the patient cannot actually decrease this 10 kgs. This is one. The other thing, there is a well-known program called preparatory program cognitive behavioral-based intervention. This is actually 7 sessions. Each session discuss all the issues that you mentioned, and this is actually preparing the client or the patient before the surgery. And there is an evidence based on this program. They minimize the complication. Also, they minimize the psychological problem, and they enhance the weight reduction. There is actually many programs and interventions, but actually the things that we depend on below qualified staff that actually may affect the intervention itself. Thank you.
Okay, so I will agree with Dr. Mishal, and let me say that it's unfair for the patient to specify percentage of weight for them to get the access to whatever, the surgical or medical. Because if the patient will be able to lose 10 to 15% or kg, why he would come to me? So he came to me because he's not able to do that. So, and he need he need help. So, and there is, if you go through all the guidelines, there is no strong recommendation from any clinical guideline that recommend the preoperative weight loss, except an old recommendation that has been included in the ASMBS guideline, and I think Dr. Abu Khater knows about it, yes, that they were putting the patient in protein diet or protein shakes, fluid diet, both preoperatively for 2 to 3 weeks, and that tend to be just for technical reason to help the surgeon to have a better field during the procedure to shrink the size of the liver. Is
liver
that right?
volume and abdominal wall fat.
But there is no any clinical evidence of benefits of using the preoperative weight loss. Actually, that's delay the management. It delayed the management, making late intervention for the patient who is coming. So I would agree with Dr. Mishal that I disagree of putting that as a parameter, and the only thing that you need that the patient has the perception and the readiness and the willing to follow the instruction. And the most important, that the patient needs support post-surgery, guys. What's going on in the practice right now is just doing the procedure, following the patient in 2-3 months post-surgery, and then that's it. That's the end of the story. And he has to live with himself. The problem, if we need to do something, we need to help those patients with the long-term follow-up. This is a chronic disease. Doing bariatric surgery is not the end of the story. This patient needs long-term follow-up. He has to keep follow-up for the rest of his life to maintain the result and to avoid the complications post-bariatric surgery.
Thank you, Dr. Ali.
About my question, yes. We are almost finished an Arabic book. Inshallah, you will see it within a few months.
Great.
About the question, the new guidelines, inshallah, will be published soon. Why it's become delayed? Because there is a new department in the Saudi Medical Health Center, and there is a department called the Evidence-Based Medicine Department, and they should revise all of these guidelines. Inshallah, shortly will include all even this point.
Thank you, Prof. Abdulaziz. Today, really a real multidisciplinary team session. I'm very happy you joined us, Dr. Mishal, Prof. Abdulaziz, Dr. Ali. And thank you all, and we'll move to the second session. Thank you very much. And we will have a final recommendation, and we'll put you on board. Thank you very much. The second session will be... sorry, we'll not have break. We'll continue the second session. Anybody can drink coffee and come back.
Good afternoon, everyone. I'm Mohammed Al-Mahdal. I'm the medical director of the Obesity, Diabetes, and Endocrinology Center in King Fahd Medical City. Thanks for the committee for inviting me, and thank you for the Ministry of Health. I will be chairing this session, and our first speaker is Prof. Ali Jaratli, who is professor in psychiatry. He is the psychiatry section head in King Fahd Medical City, and he will give us 2 lectures. The first one is about the psychological aspect in obesity, and the second one will be on depression and anxiety post-bariatric surgery. Please join me to welcome Dr. Ali Jaratli.
Thank you. Thank you very much for the nice introduction. I'm Dr. Ali Jaratli. I'm the head section of psychiatry at King Fahd Medical City. Bismillah ar-Rahman ar-Rahim first, and I want to thank the organization committee and the people here for attending these lectures. I'll try to make it very informative and easy lectures, as I think we need to simplify these lectures for people to understand our point of view. Let me use my slide projector here. So, Bismillah ar-Rahman ar-Rahim. Okay, let's see. This is the first slide. I would like to have some introduction about the brain, and then we'll go into obesity and food and psychological aspect of obesity. So in psychiatry, we would like to look at the brain as we have 3 brains, not 1, 3. The first brain we call the old brain. This is the brain we share with animals and with lizards, and we call it the basic brain or the older brain. This is what we call the survival brain. This is what protects us, what makes us live on Earth. Then we get the emotional brain or the limbic system, where we connect with other people. So this is where we love somebody. This is where we have feeling about anything. And then we have the thinking brain or the new cortex. The new cortex is when we think and we make lectures and we do complicated things is in the new brain. So the brain is intimately connected. We just do this division just for teaching purpose, but they are all connected together. The problem is in psychiatry, whether it's addiction or it's anxiety or depression, is we are not using the frontal lobe. So most of the thing we have in psychiatry is not having a good frontal lobe or not utilizing our frontal lobe. Why? Because the frontal lobe is the new brain. This is a brain that developed later on in life. So we get it when we are 18 to 25, we have fully developed frontal lobe. So the goal of psychiatry treatment, psychology treatment, CBT, anxiety treatment is an addiction and obesity is to make the patient use their frontal lobe. Most of us are not utilizing it very well. So what happened? Why? Because the brain developed from the back to the front and from from the left to the right. So the first we develop the old brain, then we have the limbic system, then we have the frontal lobe. And we tend to use the old brain, the limbic system, and the old brain first before we use our frontal lobe. That's why we become anxious before we know why we are anxious. So after this introduction, we'll start to dig into why we are becoming addicted to food and why food is very important. So when you eat this piece of cake, what's happened in your brain when you have this piece of cake and you say, this is really delicious and I need it, and I need it very bad, and I need more of it, because there is a certain a neurotransmitter in the brain called dopamine. Dopamine will be secreted when we have this. So dopamine is the early reward system in the brain. So when we eat, we have a huge increase in the dopamine. Where is the increase in dopamine? Is in the place of the brain called the ventral tegmental area. The ventral tegmental area is the old brain, is the primitive brain, is the old part of the brain. And we call it the survival brain. This is the brain that makes us survive on Earth. This is the brain that makes us love one another and make us eat and to drink. So it starts here in the survival brain or the ventral tegmental area. Then dopamine will be secreted from that ventral tegmental area to the nucleus accumbens. And the more dopamine we have in the nucleus accumbens, the happier and the more rewarded we are. So when we eat that piece of cake, we say yum. The word yum means I have plenty of dopamine and I have plenty of reward, and the brain is rewarded me for having that piece of cake and make me feel happy and rewarded. So this is the word yum means unconsciously when we have this yum, when we have this increase in dopamine, the brain develops memory for that dopamine increase, and we try to seek that in the future, more and more in the future, again and again. So it starts with the dopamine. Dopamine, which is secreted in the midbrain, that's what causes us to be hooked on that food or hooked on that drugs or hooked on that something we have. So it starts what we call in the ventral tegmental area, which part of the what we call survival brain. This is where the ventral tegmental area, it's in the middle, in the midbrain, and we say the midbrain is the old part of the brain, the old part of the brain. And it's become unconscious that this food caused us a lot of pleasure, and we try to seek that food again and again because we like that reward and we like that increase in dopamine that causes us to feel rewarded and feel happy. So let's see how the midbrain works. Let's see you are stranded on an island in the middle of nowhere, and you need some food, and you are surrounded by these sharks. So the midbrain will decide which food you're gonna take. Are you gonna take the broccoli or the cupcake? Well, the midbrain will always choose the chocolate cake. Why? Because it has more calories, it has more survival value. Now, broccoli will be good for you if you live in Riyadh and you have plenty of food and you are relaxed and happy and you want to prevent colon cancer, then broccoli is much better for you. But if you are stranded on an island, you need to choose what food is most important for your survival. And you are unconsciously in the old brain, what we say the ventral tegmental area in the old brain, will choose that cheesecake or chocolate cake because it's much, much better for your survival. So basically, to summarize the first slide, is there's two places in the brain responsible for addiction, whether it's for food or drugs or anything. These two places are the ventral tegmental area in the midbrain and the nucleus accumbens in the basal ganglia and the striatum. And the more dopamine we have increased in that area of the brain, in that highway between the ventral tegmental area and the nucleus accumbens, the more dopamine we have, the more value for that substance become, and the more likely that we're going to be hooked on that something, and that what we cause positive reward in our brain, whether it's food, drugs, alcohol, music, prayer, wherever. Love, when you love someone, when you look at this lady you love, that means she increased your dopamine in that frontal lobe, in that ventral tegmental area to the nucleus accumbens. So without this, we will die. Like if we came to a cat and took her nucleus accumbens away, she will sit in that corner, she will not eat or sleep, and she will not do anything, and she will die in a few days. That's how important the nucleus accumbens is for our survival and the ventral tegmental area. So without it, without that increase on dopamine, we will not have any motivation. We will not have any thinking. The frontal lobe will not work unless we have plenty of dopamine in the frontal lobe. That would make us survive with this dopamine. So ventral tegmental area is part of what we call the midbrain, the older brain, the survival brain. Without it, the survival brain is what tells us what to do, how to eat, how important that things and how not important the other thing. This is what drive our behavior and drive our motivation. When we have low dopamine in that area of the brain, we feel depressed, we feel unmotivated, we feel unchallenged, and we don't want to do anything. And it's very common in depression and all other. So this is what we call the survival brain, and this is what is, by evolution, is the part of the brain that make us survive on Earth and make us live the way we are. And the problem is when we have something that increases dopamine, that increase in dopamine will develop memory for it, not only for that substance, but everything around it. For example, when you are addicted to alcohol or food, you are not gonna develop the memory for that food or that alcohol, but you will develop memory for everything around it. So you remember the bar and the people at the bar, the smoking, the sound, the music, all of that will be recorded in your brain as a survival value. So most of us will feel hungry when we smell the food, because the smell of food is part of the whole equation of feeling survive on this earth. So what happened is the brain has memory for something is good. For example, why we like more capsa than cucumber. You will never invite somebody, let's have some tomato or cucumber together. We always want to have food together. Why? Because capsa will increase dopamine much, much more higher than cucumber. That's why we become more addicted to that, because capsa has much, much value in terms of increasing dopamine in our brain. That means capsa has a lot more survival value than cucumber. And that's why the reward in capsa is much, much higher than the reward in cucumber. And our brain has memory of that, and it is engraved in our brain, and that's why it's very hard sometimes to lose weight, because of that bad memory that we have and that important value of that substance in our brain. So we said food and sexual activity will increase our dopamine in the frontal lobe. They increase it to moderate level. Let's see, for example, in the Nicholas accumbens shell, it will increase from 100 to 150, 100 to 200. This is what we call the homeostasis. This is our brain, when God created us, put us this survival value to make us live on earth. The problem with drugs, for example, we're going to talk a little bit about the drugs. For example, like amphetamine and kryptonite and cocaine, they increase the dopamine in about 10 times as much. That's why when you're hooked on amphetamine or kryptonite, you are increasing your dopamine. So we said our food and sexual activity will increase from 100 to 200. But kryptonite will increase it to almost 1,000. So it's 10 times as much. That's why people hooked on that very quickly. And the other thing that is important, like food and sexual activity, will be meaningless because you change your hedonic tone from 100 to 200 to much, much higher level. And that's why normal reward like food and sexual activity will mean nothing. So why it's very hard, like Dr. Mishal and Dr. Al-Uthman mentioned, that it's very difficult for a patient to lose weight. Why? Because we are, by evolution, our limbic system and emotional brain and reward system is much faster because they are part of the old brain. The old brain is always come fast. Old brain work much quicker than, so when you see the pizza or the capsa, your limbic system and your old brain will become very activated, and you eat that pizza before you realize that it's not good for you to eat too much of it. So the cognitive brain or the new cortex come always a little bit later. So most patients, when they see the capsa, when they see the pizza, they know that it's bad for them, but it's very hard for them to realize it because the emotional brain, the old brain comes always faster. Why? Because it's old brain. So most of us knows how to use the old brain first. The new brain, we tend to use it a little bit later. So always this one become, so part of the treatment of, that's why Dr. Abu Khater and I emphasize about the importance of psychology and psychiatry in treating our obese patient is we need to teach them how to use the frontal lobe, because most of us will delay the frontal lobe. Why? Because when the reward is very high, the limbic system prevents the frontal lobe from interfering. So when you see that capsa, it's so important, it's gonna raise your dopamine hugely, then your limbic system will prevent the frontal lobe from interfering. And God knows our weakness, that's why, for example, same thing in intimacy. That's why we are not supposed to be with one lady alone in a place. Why? Because the reward will be great, the limbic system will prevent the frontal lobe from interfering, and then we get in trouble. That's God, knowing our weakness, told us not to be to not cross the red line, not to be with one lady alone, because he knows our weakness and he knows our frontal lobe will not be able to overcome the limbic system because it's so hugely rewarded and we are not supposed to make any mistake. So, and that's part of the treatment that...
2 minutes left for...
I have 2 lectures.
Yeah, for the first...
Yeah, I mixed them together. So, okay, so they are all the same. So part of the treatment of obesity is always, I tell the patient before you eat, let the frontal lobe interfere. So you look at this piece of donut, and if you are able to pause for 5-6 seconds before you eat it, then you try to make the frontal lobe interfere and tell you the value of the donut is not as good as or the reward of the donut will be less than the punishment of that donut, where it's going to be on your belly and make you gain weight. So if we can wait a few minutes in cognitive therapy, tell the patient just to be patient and wait and evaluate the importance of that donut, then you might not like to eat too much of it because your frontal lobe is much better in making choice than your basic older brain. And Dr. Leduc in New York University mentioned this resembling. Let's say you are in the middle of the desert and you see a snake. When you see the snake, you immediately jump. The jumping from the snake is located in the amygdala. The amygdala is part of the old brain. It take over and make you jump because amygdala have the emotional memory that tell you that this creature is very dangerous, and you don't want the frontal lobe to interfere because the frontal lobe takes time to make decisions. So here the amygdala immediately interfere and make you run out from that dangerous creature because you don't want to be a lunch for that creature. The frontal lobe is going to decide, okay, maybe the snake is not poison, maybe she is not hungry, and the frontal lobe takes time to make decisions. So God put it in the amygdala because amygdala called the low road. It takes decision much, much quicker in a fraction of a second. But same thing happen when it's very painful things. Same thing happen when it's very joyful. So when you see this pizza, because the midbrain and the nucleus accumbens remember how much reward you got when you ate that pizza, how much dopamine you have, how much joyful feeling you had, and then you immediately run and eat the pizza before you realize how bad it is for you when you ate too much of it. So it's the same mechanism that make you run from the snake, it's the same mechanism that make you go to the pizza without using your frontal lobe. So basically, as we said, we need to teach the patient how to use the frontal lobe. The frontal lobe is underutilized in our patient. We call that the conscious brain. So basically, to summarize the first lectures, is we have a place in the brain called the ventral tegmental area, and we have a nucleus accumbens, and the more dopamine we have between the ventral tegmental area and the nucleus accumbens to the frontal lobe, the happier we are. So when God sent us to earth, He sent us something to feel rewarded. Most of it is food, water, sexual activity, nourishing, that means good things when we say good things to people, music, art, prayer, all of that, family, all of that have in common is by increasing your dopamine. Now, for me, I don't think this strawberry will increase my dopamine. This is what increase our dopamine. This is what increase our dopamine more than this one. So feeling of pleasure, feeling of reward is related to how much dopamine we have in that nucleus accumbens. And it's related to food or drugs or anything that increase our dopamine in life. Marriage will increase our dopamine. Having intimate relation will increase our dopamine. Feeling in love with someone will increase our dopamine. And that's why we like to repeat the thing that make us feel good. Why? Because our frontal lobe will not work unless we have dopamine in it. So that's why when you are hungry, you feel tired and sluggish. When you don't sleep, because sleep will increase your dopamine, you feel sluggish and tired and have no motivation. Dopamine is in the frontal lobe is what make you feel who you are and make you function and make you feel normal. So dopamine is a part of the thing that make the frontal lobe utilize very well and be who you are. Now, God always wants us to create things in balance. So we don't want to be a victim for our midbrain and nucleus accumbens. So the reward system is always supervised by two parts of the frontal lobe, the orbitofrontal cortex and anterior cingulate cortex. This is very two vital part of the frontal lobe that make us balance our needs. So the midbrain want to eat all the pizza. The midbrain want to eat all of the capsa. The frontal lobe is the part of the brain that make you balance. You're gonna eat some, but you don't want to eat too much. So it's what balance our need for substance that increase our dopamine. So always the balance is between the function of the frontal lobe to the nucleus accumbens and the midbrain. So the midbrain wants you to survive, doesn't care about cholesterol, blood sugar, halal, haram, doesn't matter. He wanted to survive, and that will increase your dopamine. The role of the frontal lobe is to balance that out. The problem when we see patients with obesity, severe obesity, or severe addiction, that means their frontal lobe is not able to supervise that midbrain. It has a weak hypofrontality where it's not able to balance that out. So by therapy and medication, we try to make the patient have more balance in that equation. We call these patients who had severe obesity, patient who had drug addiction, patient who had severe anxiety. That means they have what we call hypofrontality, or their frontal lobe is not strong enough to manage that seeking sensation that cause them to have immediate reward. They want it very bad. So when we have damage of the frontal lobe, that's what causes you to be overindulge on things, whether it's food or sexual activity or using drugs. This guy, for example, because the reward of that hamburger is so good, because the nucleus accumbens and the ventral tegmental area had a lot of dopamine when he smells that hamburger, he will have very weak ability to handle his need for that hamburger, and he will munch on it without looking at the consequences of his act. The problem is that huge increase in dopamine in his nucleus accumbens. The frontal lobe is unable to balance that out in any ways. Now, there is always a role of stress. Stress will disturb our homeostasis, will make us fat. Stress is one of the major factors that make us obese and fat. Why is that? The cortisol, when we are stressed, we secrete a lot of stress hormone, cortisol. The problem with cortisol is it will inhibit the frontal lobe. So cortisol kind of disconnect the neurons in the frontal lobe, make them weak. And we said having a good frontal lobe is important to balance the need of the limbic system. So the frontal lobe is the part of the brain that tells us is enough is enough. You don't want to eat too much. You don't want to drink too much. You don't want to have any drugs. The frontal lobe's job is to balance that midbrain. And when we have stress, the stress works directly on the frontal lobe and make the supervision of the frontal lobe much weaker in controlling that sensation in the limbic system. So the combination of stress and increase in cortisol will make you very put you at vulnerability of addiction. In fact, if you look at if you work in addiction and you see that, let's see, you see some patients who are addicted to smoking or addicted to food, and then they get better. The minute when they relapse when they have any stress in their life. So most patients will go back to smoking, drinking alcohol, or indulge in eating after they have any stressful event. Why? Because the stress will decrease your dopamine, and cortisol will decrease your dopamine. So cortisol, when we have no dopamine, we want that dopamine to be quickly raised, and the quickest way to increase dopamine is eating a lot or smoking or using alcohol. So always addiction is come from stress all the time. So for example, if you are, they did this study in England, and they have 12 people. 6 slept very well, 6 did not sleep very well. And they gave each one of them 30 pounds to go to the supermarket and buy food. So the people who slept very well at night, they brought very healthy food. They brought vegetables and fruits. The people who did not sleep very well unconsciously brought this kind of food. Why? Because when you don't sleep, you start craving junk food and you start craving carbohydrate. And that's what happened. When you are stressed out, you kind of want to eat too much. So part of a treatment of bariatric patient, part of treatment after bariatric surgery is to work on the stress level and decrease the stress level. Why? Because we said cortisone will decrease your serotonin. So stress will decrease your dopamine and will decrease your serotonin. Serotonin is very important in obesity. For example, we said when we have dopamine, when we eat this cake, we have increase in dopamine. So what keeps the dopamine in track, what keeps the dopamine not going very high is serotonin. Serotonin kind of inhibits the dopamine. So if you have too much dopamine and too little serotonin, then you're going to be addicted to food and the drugs. Most patients who drink alcohol heavily, most patients who eat a lot, they have a little bit more dopamine than serotonin. Serotonin is what keeps the dopamine in check. So serotonin is like your babysitter that keep your dopamine from going very high. So when you have a stress will decrease your serotonin, so the dopamine become unchecked and you become indulging in food and all drugs. So the balance will be disturbed unless you have enough serotonin in the frontal lobe. So that's why we have some people, we call them emotional eater. Emotional eater is the people who, whenever they get any stress, they start to eat a lot. And I have a lot of patients tell me that whenever I feel stressed out, I unconsciously go and start eating. I go to the fridge and start eating. Those patients who have been sexually abused as a child, they have emotional eater because they want to decrease that pain they have. In fact, I have one lady, we call her Lady Pink. A Lady Pink had a bariatric surgery a couple of years before she saw me. And she came one time crying to my office. She was extremely crying, extremely disturbed. The problem with Lady Pink is she had very bad relation with her husband. That's why I always tell Dr. Abu Khater, don't do any surgery before to any patient unless they see me first. Why? Lady Pink does not like her husband. She had very bad relation with him. And she told me one time that she described it as he raped me all the time. She doesn't have the intimacy, she called it rape, because she hates him and she cannot stand him. She told me before the surgery, I used to, after the intimacy, I go and eat piece of pizza and I feel a little bit more calm, less intense, less painful emotion. Now, after the surgery, what happened to her? She became thin, she became more attractive, and he is having more relation with her. She told me before I used to go and eat pizza and I'll be fine. Now I cannot do that, so I have a lot of pain and a lot of emotional pain. She was crying like hell. So the problem with these patients, we need to address the psychological issues before the surgery. It doesn't mean that she doesn't have to have a surgery. No, she can have the surgery, but we need to address the psychological factor and what motivates her to do the surgery before we have the surgery, because that's going to damage her a lot if we don't do that before. So what happened is before the operation, she used to eat this capsa and pizza and she will be fine. She will overcome that emotional pain. Now she cannot do that, so she is having no dopamine. In fact, she is so painful, so depressed that causes her to have this. That's why most patients after bariatric surgery, especially in the first 6 months, they feel so depressed. Why? Because they are deprived from that dopamine. Dopamine what makes them feel high. So most of them, they replace food with the drugs. And Dr. Abu Khater knows one of our patients, there's many of them, but one of them who never smoked shisha before. After the surgery, she is using shisha 24 hours, 7 days a week. She replaced food with shisha. And this is very important point in patient with bariatric surgery. So before we do the bariatric surgery.
2 minutes.
Yeah. So before we do the bariatric surgery, we need to make sure they are not replacing the food with the drugs or alcohol, because that is very common complaint. We have many patients who replace food with alcohol or with the drugs. Why it's very hard? Because this is what happened. The memory of the food is located in a place in the brain called the hippocampus. The hippocampus is our memory. And that memory of the food is so strong in the hippocampus. So it's like when you do bariatric surgery, it's like losing a loved one. Like, for example, if you are in love with someone and that someone left you, you're gonna feel so miserable. You're gonna feel so depressed. Why? Because that guy had left you, or that lady who loved you had left. So it takes you 6 months to 1 year to just this memory in the brain to get a little bit weaker, because they are represented in your memory of the brain. So the hippocampus, the memory center of the brain, has plenty of memory about that food, about that capsa, about that food. It takes time for that connection in the brain to die down. It takes 7 months, 6 months to a year before they start dying down. And this is a crucial area where you have to work with patient about the depressive symptom. The problem is because of that strong memory in the hippocampus, you're gonna feel miserable, and you're gonna take time before this hippocampus signal to come to the frontal lobe. In fact, when you have surgery, the hippocampus keep bombarding your frontal lobe that we are feeling miserable. We want that food again. We cannot sleep, we cannot eat. Most of them will have this dream about food and memory of food, because that memory of the hippocampus is making you to be haunted and making you to be miserable. So you cave in and you want to go and eat again. And it takes time for that hippocampus to tone down that memory and take time before you feel normal again. So the first 6 months is very crucial in any patient after surgery. Most of them will gonna feel depressed. Most of them will gonna feel miserable, and they need interference as soon as possible to decrease that craving from that period of time. I will stop here because of the sake of the time, and if you have any question, I appreciate it.
Thank you very much, Prof. Ali. Lots of fascinating science in this lecture. Thank you very much. Our next speaker is Prof. Abdullah Al-Asaimi. He is a psychiatrist and a professor andrology, andrology consultant at the University Hospital, right? In the Ministry of Health. And he is going to talk about diabetes and sexuality. Thank you very much.
Assalamu alaikum. All, I am yes, we will talk inshallah today about sexuality in patients with diabetes. I'm Dr. Abdullah Al-Asaimi, consultant urology, andrology, and sexual medicine, leader of sexual health program in Saudi Ministry of Health. Shall we start? Okay. From here, yes. First, let me talk about the sexuality differences between male and female. What's the goal? What's the main goal for the female, and what's the main goal of the male for in terms of on goal of sexuality? Always the male, their goal is different because they feel the urge for the sexual release, and they search for a pleasure. And what's their target or benefit or reward from the sexuality or the sexual intercourse is for pleasing their partner, as we said, it's my manhood. So they search for pleasing their partner only for reflecting their image for themselves. And it's different than the female. The female, always they search for love and intimacy in the sexuality. It's not the release itself. It's not urged to release. And it's searching for the emotional and sexuality. And it's different. The third point, the male it's reflecting, the sexuality for him is reflecting his manhood Also for the female, she need to be feeling that she's sexually attractive for her partner. Sexual health or the sexuality itself is different for each person. It's also different for the person itself from each age group. For example, when he's young, it's different than he's in middle age or old age. It's part area that involve many interrelated specialty, endocrine, psychiatry. Sexologist is like the one who's dealing with the first presentation of the patient, and then he refer the patient when needed. It's fundamental to physical and emotional health and well-being. This is important, actually. The problem with the sexual history taking, always there is an important point to cover. The first is general medical as usual, but lifestyle, sports, smoking, it's all reflecting the image of sexuality in the person's mind. Cultural background, it's important to assess the sexuality of the patient. His degree of religion, morals, degree of sexual education, search for stressor, actually, for financial or kids, because at the presentation, maybe he will have the sexual dysfunction that is related to this point. Maybe he have a stressor or something. Yes, okay. So, as we said, search for a stressor. Psychiatric history is important, is a major important, and it's a major impact on the sexuality. Search for the history of his first experience sexually, and what's his medication, if there is any medication, and personal sexual history. It's difficult at the first, so it's difficult to ask him about the abuse. There is a way to ask him about if there is abuses or a history of sexual abuse, and what's the degree of abuse. Body image is important also in sexual history. Level of implication with the partner, this is a major factor also in the sexual history. Actually, we have deficit in the study that done in Saudi Arabia about the sexuality. This is a study done by Dr. Turki in 2017. Studied 186 men. 95% of them, they have diabetes type 2. Major part, 2/3 of them, they have partial erectile dysfunction. And nearly 11%, they have complete erectile dysfunction. As we know, I think this is underestimated, the real sales of maybe our colleague in pharmacy. They will give us the real number. 5% of all medication in Saudi Arabia is the BDA5 inhibitor, which is erection medication, or used to medicate for erection. 1/3 of newly diagnosed men with diabetes have erectile dysfunction at presentation. 50% of them, after 6 years of diagnosis, after the diagnosis of diabetes, they will have a sort of erectile dysfunction, either partial or complete. 11% of them, they will have a complete at the presentation, as we say. Diabetic retinopathy and nephropathy, it's correlate with the presence of erectile dysfunction. When you have a diabetic patient and he came with retinopathy, for example, or nephropathy, ask them about the sexual or erectile dysfunction in the male. Always it's neglected. We all, as a physician, we are treating the patient with diabetes only for glycemic level or something, and often we neglect the sexual history, which is the patient not tend to give you the problem. You have to ask the patient, because it's they feel shame about revealing this secret information. And it's also impacted on the quality of life. We can use a questionnaire to overcome this shameness for the patient. We can give them a simple questionnaire with a simple question to just search for the sexuality deficit they have. And we can use actually two gold standard in the sexuality. For male, International Index of Erectile Function, and for the female is the Female Sexual Function Index, which is both of them, it's a gold standard tools that we can assess the sexuality for both. We will talk now for just briefly for the male at the first section of this lecture. Erectile dysfunction, it's the persistent inability to attain and maintain the penile erection sufficient for satisfactory sexual performance. Prevalence increase with age. 52% of the patient or the male without diabetes, 50% of the male actually, they will have a sort of erectile dysfunction after the age of 40. Testosterone, as we know, is decreased with the age, is a major factor for sexual dysfunction in male. Causes for erectile dysfunction, either it's organic, anatomic, vascular, endocrine, neurological, or psychogenic. All adult male with diabetes should be regularly screened for erectile dysfunction. Just help your patient to reveal if he have this, because it's treatable. At the first, it's treatable. You can use BDA5 inhibitor, which is Cialis, for example, or Snafi 5 milligram. This is the first line of therapy, and we prefer it than to give the patient, for example, the Cialis 20 PRN. We prefer to use the 5 milligram daily use. It will give you better result than the 20 PRN. Always search if your patient is not responding to the BDA5 inhibitor. Search always for testosterone level. They tend to have hypogonadism, which is low testosterone, and always check for the testosterone level from 7 a.m. to 11 a.m. Okay, before 11 a.m. This is the recommendation, because we want to measure the testosterone at the highest level for the male. Refer the patient when you use the BDA5 5 milligram tadalafil, and the testosterone level was good and there is no response. Don't hesitate to refer the patient to the specialized andrologist, for example, in your area, or the sexologist. We hope, inshallah, we will have more sexologists in the future, inshallah. Men with diabetes and they have the ejaculatory dysfunction, and they are willing for kids, for example, there is a lot of option for them. We can treat them. If there is no response, we can do surgery for them, and they can have their kids. You can use also the controlled diabetic for as a rewarding for the patient. You can and this is true according to the literature. If you controlled your diabetes, you will not have the complication or the sexual complication that it came with it.
2 minutes, Dr. Adnan.
The contraindication for just a fast review for the contraindication for BDA5 inhibitor, which is tadalafil 5 milligram, is the absolute is nitrate use. The relative, even the severe cardiovascular disease, you can ask the cardiologist to clear the patient to give the BDA5. MI, stroke, less than 6 months, yes, you can ask the neurologist, but more than 6 months, you can start it. The periapism is rare, which is sustained erection more than 4 hours, and it will be painful for the patient. It's rare with the BDA5 and the 5 milligram. It's better we use the 5 milligram more than 20 because the periapism itself is lower as a side effect. This is just a diagram that you can use it for managing the patient. When you have a male patient with erectile dysfunction, if he doesn't have a contraindication for tadalafil 5 milligram, you can start it directly. If there is no response, you have to check the the testosterone level. If it's low, you can replace it by yourself. If there is no response, just refer to the ED specialist. Common side effect of tadalafil 5 milligram is headache, flushing. Always the patient, actually two in Saudi Arabia, as my clinical experience, the lower back pain, the headache, the float-like symptoms. Other modalities for erectile dysfunction treatment is intracavernosal injection, which is directly we can give the patient prostaglandin and he can inject the penis itself. We use this for old age, actually, and when this is the last option prior to the surgery. The complication, the periapism, is more with this type of treatment. Pain and fibrosis, usually after 1 year, they need, due to the fibrosis, they need penile prosthesis. Hematoma at the site of the injection. The contraindication for intracavernosal injection is the sickle cell anemia, because sickle cell anemia, it will increase the periapism possibility for the patient. Schizophrenia, the psychiatric problem, they not injecting at the site, at the proper site, and this may lead to injury of the penile tissue, severe systemic disease, and stable coronary artery disease, because we go directly to the system. And for penile prosthesis also, we cannot use this because it will puncture the cylinders, and it will the penile prosthesis only it's a replacement of this. This is the prosthetic surgery for erectile dysfunction, which is penile prosthesis. We have 3 types of penile prosthesis. We have the malleable, and we have the inflatable. The inflatable, we have 2 types, actually, 2 pieces and 3 pieces. The idea of the penile prosthesis is to replace the normal pathway with the artificial pathway of erection. We replace the erection tissue with 2 cylinders and a pump, and the principle is very simple. We use the pump to inflate saline in the cylinders, and we will have the erection. The indication, when all the modalities of treatment is failed, we can go for erectile dysfunction, neurogenic bladder also. Contraindication is like any surgery, the coagulopathy, uncontrolled diabetes, because it will increase the risk of infection, and poor surgical risk. The hypogonadism in male with diabetes is common, and it can reach 40%, and some studies showed until 60% of them, they will have low testosterone. The hypogonadal men with diabetes, they have more or higher risk for cardiovascular mortality than the eogonadal men. We recommend to do the screening for testosterone for any patient more than diagnosed with more than 5 years of diabetes. Don't hesitate to measure his testosterone, as we say, from 7 a.m. to 11 a.m.
Time is up. No, if you
the most important, the female, they will have. Just the take-home message: screen all men, treat, referred, investigate that testosterone, referred if there is no response. Just the female, I will take short because it's total of 27. This is study, the last study was published for Saudi Arabia. 275 lady with diabetes type 2, 88, nearly 90% of them, they have a sort of sexual dysfunction, FSD, female sexual dysfunction. It's increased with the age, of course. This study found there is no relation with their glycemic state and the sexual dysfunction they have. Defined as disorder of sexual desire, orgasm, or arousal, or pain for the patient. It's common. Uncontrolled diabetes in that study was unrelated to the sexual function, but in my clinical experience, I found that a lot of females with diabetes, uncontrolled diabetes, they affected because they will have more UTIs, more vaginitis, so it's indirect way they will have it. The exact reason for low libido for the female is unclear. We need more research. Depression and anxiety from the disease itself or its complication, as we said, recurrent vaginal or urinary infection will interfere with the sexual activity. This is the female sexual function index is a great tool to assist the female for sexual dysfunction. Thank you.
Thank you very much, Dr. Abdullah. Please join us here. Dr. Ali, please join us here on the panel, and probably we'll have a couple of questions before the break. Maybe I'll start. Dr. Abdullah, what do you think? Is there any rule for the vacuum device for erectile dysfunction in patient who has contraindication to phosphodiesterase inhibitors?
Actually, the problem with the vacuum is we use it for the old age, but the problem, the outcome is not that much. We, as Arab male, they need a fast and effective way. So the vacuum for them is, they want the rigidity to be 100% or more than 80%. We cannot reach this percent with the vacuum device. We use the vacuum actually in Saudi Arabia, and it's not approved from the Saudi FDA. Okay, but we use it for Peyronie disease as a modality of treatment or lowering the degree of angulation of the penis.
Yeah, I have seen this used more outside the kingdom, not in the kingdom.
Yeah, because outside they use it to have 80 or 60% they can benefit. But for us, our culture, we need it either all or none, okay. More than 80%.
All right, I guess we have one question there. You have the mic.
Thank you very much. Professor Ali, you prepare us for the lunch with this cheesecake and thinking about these nice pizza. Now we have a subspecialty of medicine called culinary medicine. Means that how can we prepare pizza, burger, kabsa, all traditional foods healthy. For example, we started already to do this, and instead of make it easy to be understood, for example, traditional foods, instead of doing gursan with vegetables, we're doing vegetables with gursan. Means increasing the fibers at the same time with the low glycemic index of pizza, attractive pizza, at the same time high fiber is suitable for patients. So maybe this will help actually to control some of these.
Yes, I'm part of that, by the way. I'll be in Ha'il next week, inshallah. So I'm participating in that, inshallah. And I think it's a brilliant idea to do that. I think it will help a lot.
Excellent. Any more questions or comment?
السلام عليكم دكتور عبد الله. For intracavernosal injection, still papaverine HCl indicated or not? Papaverine HCl.
Yeah, we can use it.
Okay.
We can use it, yes. It's depending on the center. But for me, I prefer it because there is more effect than using prostaglandin يعني alone. The trimix is better than bimix is better than Caverjet. يعني as I noticed in a lot of patients. Yeah, we can use it.
Thank you.
Okay, thank you very much again for our speakers for the fascinating lectures. I think we will have one lecture by Abbott Company before lunch. Then after that we can go for lunch.
Assalamu alaikum. يعطيكم العافية. Thank you very much for your attendance today. My name is Ahmed Al-Mosli. I'm the responsible of the marketing for Abbott Diabetes Care in Saudi Arabia and Bahrain. And I would like to walk you through the new technology of diabetes with the flash glucose monitoring technology highlighted by the Freestyle Libre 2 and how it really helps patients live their life to the fullest. And I will take around 15 to 20 minutes maximum to finalize these slides. So starting with our theme. Our theme is considering the patients as well as the HCPs, the ones that they are facing diabetes day by day. So when we start our theme, when we launched the Freestyle Libre in the first beginning, we said patients can do it without lancets. But now, after launching the Freestyle Libre 2 with the enhanced diabetes technology in terms of alerts and alarms, so patients and HCPs know, now they know about this burden and how can they really help their patients live their life to the fullest and how can they really manage their diabetes. So I will start with the needs behind the technology. As you are aware, using the blood glucose monitoring technology is really hassle for the patients because of the invasiveness. And as this study shows that most of the patients who are using the blood glucose monitoring technology, which is the glucometers, they will not be able to control themselves to the optimum levels due to the invasiveness and the skipping of the social unacceptability of using the blood glucose monitoring technology with the finger pricks. As you can see from this graphs, patients who are using the SMPGs, they can only know about their current diabetes status. While using the CGM technology with the Freestyle Libre, the flash glucose monitoring technology, they can know exactly all the fluctuations that happen during the day using this technology. Another important parameter, which is the ambulatory glucose profile, which shows how this patient is behaving throughout the 14 days or 30 days or the 90 days. As you can see, for example, there are 4 patients here who have the same approximately HbA1c. If we come to the clinic, do you think that it is applicable for the HCP to treat those patients the same, even though they have different parameters? I believe not, even though they have the same HbA1c. So we're talking here that the full glycemic picture was unseen before. But now with this technology, by knowing the glycemic profile in terms of variabilities, hypoglycemia and hyperglycemia, now the HCPs have all the knowledge on how to treat their patients in the right way. Another important parameter, which is now one of the cornerstone in diabetes technology treatment and approved by the IDF, ADA, ASD, all the guidelines, which is the timer range. Timer range is very important because it complements the HbA1c as a parameter for the HCPs to treat their patients. So as you can see, achieving more than 70% in the timer range, which is the time between 70 and 180 milligram, is really important for the patients in order to be controlled. And it shows that these patients who have this type of control in terms of timer range it means that they have an HbA1c which is around 6.7%, which is controlled. That's why it's really important to highlight the timer range and the importance of timer range. Why is it important? Because this study shows that every 10% decrease in timer range, it means there are 64% increase in retinopathy and 40% increase in microalbuminuria, which means that the more you have your timer range is increased, the better your complications will be. So as you can see, this is according to the guidelines. When you achieve 70%, which is equal around 6.7% in terms of HbA1c. And every 10% increase in timer range equals to around 0.8% decrease in HbA1c. So this is really important to show that whenever we can control our patients to increase their timer range, they will have better HbA1c. So this is to introduce the Freestyle Libre, the flash glucose monitoring technology, which as you can see, it doesn't have any calibration, no finger pricks at all, and with every, it stores, measures the glucose 24 hours, which means that the patient is aware all the day about their diabetes. And all what you have the patient to do is to scan their sensor every 8 hours in order to have a full 24 hours daily graph so that they control and manage the diabetes. So our system includes the Freestyle Libre Link, the application that you can use by your mobile to scan your sensor, and also the Libre Link app, which is an application to share the glucose with the loved ones, the caregiver. For example, a child can share their glucose with his mother, for example. Whenever he scans, the data will be transferred to his mobile. And finally, the professional diabetes management system, which is the LibreView, which allows the HCPs, the doctor in his clinic, to receive all the data of the patients in his clinic and manage his patients remotely by having all his reports in his laptop. As you can see, this is the sensor, and this is the only 14-day sensor in Saudi Arabia with this size. And it is water resistant, so the patient can swim and there is no worries or have a shower with it. And also re-emphasizing on the use of the Freestyle Libre Link, which shows that patients who are using the Freestyle Libre Link, comparing to the patients who are using the device, have higher timer range by 5% comparing to the patients who are using the device. So it's better to use the application than using the device. This is the LibreView, which is a diabetes management system, and it's really important that, and it's really easy to do. All the patient need to do is to connect his account with the HCP account by one click through the application. And whenever he scans, all the data will be automatically uploaded to the cloud on the LibreView and will be shared with his doctor in the clinic. And the doctor will be able to see all the glycemic profile of the patient remotely, and also to manage him remotely, especially for the rural areas, remote areas, etc. LibreLink App, as I've mentioned, it is for the caregivers and for the loved ones. And this is our core systems in terms of Freestyle LibreLink, LibreView, and LibreLink App. Now, what is the main difference with the Freestyle Libre 2? You know, the Freestyle Libre 2 offers optional, real-time optional glucose alarms whenever there is a high glucose or low glucose or signal loss. So whenever the patient, for example, have a hyperglycemia, alarms will come up, and also whenever he has low or hypoglycemia, low glucose, also alarms will come up. And also there is a time, there is a range that it can be settled, and once it is there, so the patient will have a real-time option glucose alarm. So the patient doesn't need to scan. It will come automatically with an alarm that, for example, you have a hypoglycemia, scan to take an action. So our theme is to scan, alarm, scan, and act, as you can see. Now, just to walk you through quickly in order not to waste so much time with the clinical evidences that the Freestyle Libre 2 has. There are a lot of studies that has conducted for the efficacy and also the clinical evidences with the Freestyle Libre 2 to help their patients live their life to the fullest. And mainly by increasing the timer range, reducing the hypoglycemia, and decreasing the A1C. There are local studies as well as international studies. And also we have local studies by the Ministry of Health, which is the largest one in terms of group, which shows the baseline was decreased after the use of 2 years of the Freestyle Libre 2. And this is really important to show the clinical evidence that the Freestyle Libre can help their patient to reduce their HbA1c. Also, we have multiple studies in the Prince Sultan Military Medical City to show that the Freestyle Libre can reduce the hypoglycemia, reduce also the HbA1c, and also increase the time of range on all type of patients, whether they're type 1, type 2, MDI, or IOPs. So starting with a very important parameter, which is the time of range. This study called the IMPACT study, which was targeting the type 1 patients. As you can see, this study shows that these patients could increase their time of range by 1 hour per day, which means that they will become more controlled by having this technology. Also, another real-world evidence for more than, as you can see, 5.8 million Freestyle Libre sensor and 1.71 billion hours of glucose reading, which is a huge data, shows that those patients has increased time of range by 43% from the timeline in terms of 4 years. And also, the IMPACT study in terms of hypoglycemia shows significant decrease comparing to SMBGs by 38%, and the nocturnal by 40%, and the serious hypoglycemia by 50%. Also, for type 2 patients with the REPLACE study, shows a reduction by 43% comparing to SMBGs, and the nocturnal, which is the overnight hypoglycemia, by 54%, and 53% for the serious hypoglycemia. Also, in terms of HbA1c for type 2 MDI patients, this study comparing to SMBG shows a decrease by 0.82%, which is a difference of 5% from the SMBGs in terms of reduction for the HbA1c for this type of patients. Also, in terms of meta-analysis of all the clinical studies, which were around 29 studies for more than 1,700 patients, it shows 0.55% decrease in HbA1c for all type of patients, whether type 1, type 2, MDI. And also, this study shows that all type of patients who are using the rapid insulin, basal, or non-insulin users shows a significant reduction in HbA1c for these patients. So we can say that the Freestyle Libre is the recommended type of technology for all type of patients to use the Freestyle Libre 2. Also, to show in terms of cost effectiveness, how really the Freestyle Libre can help patients reduce the hospital admission by 66%, also the DKA by 33%, which is really important to reduce the cost in terms of hospitalization. And also, in terms of absenteeism, we know that diabetes patients, because of their disease, they have a lot of days that they go off or sick leave due to the disease. Patients who use the Freestyle Libre have a decreased rate of absenteeism by 58%, which means the productivity for those patients became more when they use this system. Finally, also to show, also for the pediatric patients, this study called the SELFIE study showed that pediatric patients who use the Freestyle Libre have an increase in time of range by 1 hour, significant decrease in HbA1c by 0.4%, and reduction in terms of finger pricks by 79%. And also, we need to recognize that pregnant patients with diabetes can use, in terms of gestational diabetes, can use the Freestyle Libre, and it is approved for use by the FDA and SFDA, and it shows really important, significant reduction in terms of HbA1c and also hypoglycemia. Finally, to sum up what I was saying, that now patients can see their complete glycemic profiles. So we need to help them achieve better outcomes. So we're talking about the sensor who has the best accuracy in Saudi Arabia in terms of treating, and no confirmatory finger pricks are required at all when you need to treat your patients in terms of insulin adjustment or whatever, only with one case with the hypoglycemia if the symptoms are not the same as the expectation in terms of readings. So in this case, you need to double check by blood. Other than that, you can rely 100% in terms of relying. It has optional glucose alarms, clinically proven, as I've mentioned with the studies, and easy for the doctor and the patients to control their patients for the long term. So by this, I'm finished with my my slides. And if you have any questions, please let me know. Thank you very much. Any questions?
السلام عليكم. شكرا للجميع، شكرا لجميع الحضور. يمكن الآن في ما قبل المحاضرات البريك الأخير كان عندنا فرصة جميلة. قلت أستغل الفرصة هذه بتقديم الشكر الجزيل لسعادة الدكتور محمد العقيلي. طبعا الدكتور محمد العقيل يعني علم في مراكز جراحات السمنة من فترات ماضية، هو شغال معنا في الوزارة ومن مؤسسي العديد من المراكز ومن واضعي مؤشرات الأداء وكذلك التصنيفات، وكذلك ما زال معنا كمستشار في الإدارة. أمس كنا حريصين على وجوده معنا، لكنه ما شاء الله تبارك الله هو كان، احنا ما نبغى نقول انه خارج المنطقة، لكن فعلا يسمح لي أقول أنه كان في تبوك أجرى العديد من العمليات أمس أثناء افتتاحنا للملتقى، وحرصنا على تواجده. واليوم معنا الدكتور محمد. تفضل دكتور محمد الستيج. الله يعافيك إن شاء الله. تفضل دكتور طارق رائد.
شكرا لحضور الدكتور محمد العقيل وعلى المجهودات اللي قدمها، والدكتور عبد الله السهيمي يقدم لك شهادة تقدير وشكر.
شغال. السلام عليكم. يعطيكم ألف عافية وشاكر لكم جهودكم لإدارة المراكز المتخصصة. يعني كما تعودنا سابقا، والدكتور يعني أبو موسى ما شاء الله تبارك الله يعني له بصمات واضحة خلال العام هذا والعام اللي قبل. أتمنى إن شاء الله يعني أنه تستمر هذه الجهود، والحمد لله يعني وجود يعني الدكتور عبد الله والدكتور رائد ما شاء الله تبارك الله يعني لهم بصمات سابقة وحاليا يعني ما شاء الله تبارك الله. وأثني جدا يعني على المؤتمر هذا، سعيد جدا يعني أنه تواجد اليوم، لكن كان يعني أمس فرصة، لكن أعتذر يعني عن عدم الحضور زي ما تفضل الدكتور عبد الله. والله ما وصلنا لمتأخر بالليل، لكن الله يعطيكم الصحة والعافية، وشاكر لكم التقدير على التكريم هذا اللي فاجأتونا فيه. شكرا لك إن شاء الله.
And prayer will come back to the, inshallah, to the complete the session of scientific session. Thank you. But please come back, huh? All of you. Okay, good afternoon. We are going to resume the last two sessions of the second day of our conference. We'll start now with Dr. Ahmed Al-Ghamdi. He is a consultant bariatric surgeon in King Fahd Medical City. His presentation will be the surgical treatment for low BMI patients with diabetes.
Assalamu alaikum, everyone. Thank you, Dr. Abu Khater. Thank you, everyone. You can start the presentation. So just before we start the presentation, so as you can know, there is my talk will be more of interactive talk rather than one-side talk, because my subject basically is something updated, and somehow the new guidelines was issued last December. Finally, the two big surgical organizations, SMBS and EFSO, agreed for surgical intervention for a BMI or obesity class 1 BMI from 30 to 35. So things a bit, I would say it's a new for a practice, yet most of the surgeon, and we are still, I would say it's a new subject, so it's a more of something will happen in the future rather than it has a lot of history in the past. Is that working? Yeah. So as I mentioned, in last December 2022, so 5 months back, the new guidelines mentioned clearly that if the patient is a diabetic and has obesity class 1, the intervention, surgical intervention for treatment is now one of the guidelines. So basically, here the challenge coming from a lot of aspects. That's why the surgeons, and it's a more of a multidisciplinary team rather than it's a one unit decision. So most of the patient on that kind of BMI does have a lot of hesitance for surgical intervention instead of medical treatment. Also, our colleague in endocrine has, I'm assuming, the same concept. So in order to jump to conclusion for surgical intervention, I think it's still growing. And I would, in the beginning, I would like to hear some, if you do have the mic, mashallah, we have here Prof. Naimi and Dr. Sani, big names with brief history. So if you can give them the mic and tell us, please, in your experience, are you happy to do them surgical intervention, either sleeve or a bypass for class 1 obesity?
Sure, thank you very much. It's, as you said, it's a new guideline, and it's mainly for type 2. Yes, you can go for sleeve, not more than that, because of the consequences of Roux-en-Y and venous gastric bypass on this BMI. They might become so slim, and they might not like the outcome of this surgery.
Even with if you play with, so you go with more restrictive rather than malabsorptive.
Exactly.
And even if you play with the biliary and elementary in a bypass, you still prefer sleeve?
بالنسبة with regard to bypass, it depends on how it's controlled. If it is poorly controlled medically and it's what we call it يعني مقاومة resisting diabetes, I might go for mini gastric bypass if there is no reflux, or Roux-en-Y gastric bypass, considering the original and the standards limbs of 75 biliopancreatic and 100 or 150 enteric limbs. That will be fair.
Do you have a criteria for A1C before going to surgery? Do you strictly ask the patient to control diabetes in the blood sugar? I mean, do you ask for specific number A1C as a preoperative, or regardless, you just take them to R?
Of course, this is according to the ERAs. A1C should be less than 10. If
Less
it
than
is,
10.
yes, if it's more than 10, patients better to be managed medically. But sometimes we face resisting patients, even you do whatever medical treatment and they don't go below that 10. In that case, you can admit them and start them on insulin infusion. And then perioperatively with insulin infusion, then you can do your surgery.
Many thanks for your Prof.
Also, you can hear from
the
the more expert, Dr. Sana.
شكرا أبو يحيى. I'll tell you how I've done low BMI bypass in patients insulin dependent in 2010. So my history with doing this a long time ago.
So we have
so I've done it, and I'll
are
tell
13
you
years ahead.
And I'll tell you the way I look at it. If the comorbidity can be fixed by bariatric surgery, you should go for it. And in fact, there was a white paper done by the IFSO in 2011 talking about low BMI surgery, and they've discussed this issue. Now, the fact of what to do, that is, I think, is a subject for hot debate. And in fact, we are releasing our paper. We have a paper in the process coming of showing why we disagree with most of the scoring systems today. Because you have the DRS, you have the IMS, you have Armenian, you have the ABCD of WGLE, and you have the DRM score. So all these scores focus on two things. Basically, whether he has insulin reserve or not. So if you have a patient who has a very high BMI, I think any procedure will help him.
Exactly.
The low BMI is the tricky ones. Whether they have the insulin pump or the pancreas is working or not. So C-peptide may work, may help you to decipher which patients will benefit. We have a paper where we talk about GLP-1 agonists helping us in deciding who will benefit. And then the choice of the procedure is basically subject to those terms. So we are working on trying to find out a way to predict for the patient. Because the patient will come to you and say, which procedure will give me the highest outcome and the least side effects? And that is the tricky part that nobody has answered.
Perfect. So, as a conclusion, you more go with malabsorptive procedure rather than restrictive.
I go with the different terminology. I say with more hormonal, because there is a hormonal effect on the pancreas. You have a GLP-1 agonist effect of bypass stronger than in sleeve. You do have a GLP-1 agonist even in sleeve, but it's minor. The effect in bypass is bypassing the duodenum. If you believe in the theories, it does work. And that is why we go for the bypass rather than for the malabsorptive component.
Do you restrict A1C preoperative to be controlled as a preoperative, or you can go above 10?
I don't, because of two things.
Yes.
I've seen patients who are compliant, like Abu Yahya said, I agree with him. Patients who are compliant, and you cannot bring them down, you have to operate on them. The non-compliant, regardless of their A1C, you have to discuss with them why are they not compliant so their A1C is high. Is it dietary, or is it they're not taking their medication? And then make a decision whether they're suitable to go for bariatric surgery without giving them a lesson on being more compliant and more punctual. That is how I look at it. rather than safety. Safety, I don't think plays a role because I've done A1C of 16 on many occasions of significant.
Yet
patients.
you didn't see any problem with the wound healing,
No
what they are
difference.
mentioning.
No difference whatsoever, because you're curing it.
Yes.
And that's the difference.
And this is where with our partner, the medical point of view, they said, I referred the case to you because I could not control the diabetes. That's why I refer him to you as a surgeon. So this is where we want to meet in a halfway, I would say, and hopefully for the patient's sake. So I will just go slow. So this is as with a summary of recommendation. I just want to mention about this study. So it has been done in 2020 that showed that the patient with low BMI who under surgery achieved a normal weight comparing to the people with higher BMI. So that lean more forward to the people with high morbidity to start the surgical intervention as early as you can. Another subject I want to mention about the Asian population and the BMI classification, still this is area I would say also gray. So my talk is more of a gray area than solid. Yet I don't think we can still operate with the Asian. No one will take 27 BMI with the diabetes and do a major surgery. Do you agree? Do you take 27 BMI for surgery if you go with the Asian classification?
Here it is again. If you look at the Canadians, for example, they went away from BMI totally. Let's not talk about BMI, let's talk about obesity. In terms of, are they obese and for that reason they've developed this? Or are they the thin people that don't have diabetes and they've developed diabetes? That's a different story. So often I've done 29, 28.
Okay.
And they've improved, and it always depends on. I've had a patient with a heart attack, cholesterolemia, hyperlipidemia, everything at BMI 29. So you have to cure the comorbidity if you believe it is caused by obesity. So central obesity, for example, visceral obesity, then it might be worth considering rather than.
You go with Dr. Prof. Naimi, do you go with the 28 with the uncontrolled diabetes?
Yes, definitely. If it is poorly controlled, the BMI, as you know, is not an accurate measurement of obesity that you can build on it every decision. The lower the BMI than 30, if the patient is poorly controlled, etc., I think and there is an indication from the medical point of view and side that we cannot do better than this, then you go for surgery. And again, I always start with the mildest and see the outcome. If it is satisfactory, the glycemic sugar is controlled, that's the aim. Because, if you do bigger surgery, they might go very low BMI. And they might go to hypoglycemia even.
Yes.
Especially with bypass.
Yes.
So you gradually start with the mildest, and if this is not helping or there is a recurrence of weight, then you can do the bypass at that time.
Good.
But I'm backfiring the same question.
Sure.
What about if it is type 1 diabetes?
Yeah, that's it. So the guidelines, I think, they will, for sure, we know they are insulin dependent at the end, but at least they will go with lower dosing when they lose weight instead of higher dosing. They will not be cured. And this is, as you mentioned, thankfully, a lot of patients has the concept that once I lose weight, they compare themselves with the type 2. And we've been asking in the clinic, I'm going to be cured or no? So I think we have to clarify. But in a practice, they lower, do you agree that their insulin medication dosing, when they lose weight, it goes down, and that's, I would say, enough for them as a pleasure. No need to be cured as a type 2. So do you consider that also for type 1?
With type 1, the mechanism is quite different. And the lack of insulin production from the pancreas can be compensated by giving oxygen from which is from outside. I mean, synthetic insulin, and they usually respond to that. But if there is an issue of patient compliance, there is allergy to insulin, or there is a problem with this insulin, I think you still can go for surgery. And as I said, start with the restrictive, and then progress according to the response.
Thank you.
Dr. Ahmed, sorry to interrupt, 2 minutes.
Yeah, okay.
Can I just one comment on the type 1? Type 1 should be operated for reasons other than diabetes.
Sorry, come again?
They should be operated for other reasons than diabetes.
Sure.
Ali Aminian wrote the paper, Carlos Ranvieri wrote the paper on 14, and the other one on 12 cases. I submitted to Ranvieri 8 of my cases. And the type 1 we did because they were high BMI. And why do they become obese, though usually they're thin? Because they play with the insulin. They give themselves more insulin, they eat more. They give themselves more insulin, they eat more. And it's usually familial obesity. And he develops type 1, he loses weight, then he starts back because of a familial tendency to gain weight. So you do it for other reasons like hyperlipidemia, hypertension, etc. But for diabetes per se, I don't operate. And in fact, even in type 2, if they have a depleted pancreatic stores, so they don't have C-peptides, I would not operate on them if they're low BMI. And I keep telling them, I will not operate. I would measure C-peptide and I would not do them.
Many thanks. So this is the conclusion. As I mentioned, will be the end of my topic. So it's a new guidelines, and I will base mainly and very thankfully for Prof. Naimi and Dr. Sai, because it's a more of a future practice rather than a history practice. So hopefully in the coming days we will reach a point that I would say agreement point. And thank you for your time.
Thank you, Dr. I think this is a very nice interactive talk, and we encourage all of us to do like what Dr. Ahmed did. Thank you so much.
Thank you, Dr. Ahmed, for your interesting topic. Now I'm really glad to present Dr. Mohammed Al-Mihdil. He is a consultant endocrinologist at King Fahd Medical City. He will present the future of insulin delivery devices. Welcome, Dr. Mohammed.
Good afternoon, everyone. Thank you very much for the organizing committee for inviting me. It is really a pleasure to be here. I will do 2 presentations. Number 1 is the future of treatment of diabetes in general, and probably will focus on the insulin delivery devices. The second one, we will present King Fahd Medical City experience with the hybrid closed loop system for the treatment of type 1 diabetes. And go up. Yeah, let's start with this. Yeah, the control IQ. Yeah, this one, let's start with it, no problem. Okay, so we'll start with the experience with the hybrid closed loop system, since we have this presentation ready. So we had so far 32 patients on the advanced hybrid closed loop system, and for those who doesn't really have experience with that, this is a system composed of insulin pump plus a sensor. And the sensor will send signal to the pump. The pump will adjust the basal rate based on the blood sugar. This will increase and decrease the basal rate as needed. It will also give an autocorrection boluses if the blood sugar is very high. The patient still need to do carb counting. They still need to do a bolus before each meal. So we have 32 patients on the control IQ systems. We have so far in the kingdom 2 hybrid closed loop system. The first one is the control IQ, and the second one is the Medtronic 780. Our experience, this one is with the control IQ system with tandem pump. And we have so far 32 patients, 75% adult and 25% children less than 16 years of age. Most of the patients were on CGM before, or continuous glucose monitoring system, before starting the pump, except one patient. All moved to the control IQ system with tandem and Dexcom system. The patient received support from the Vital Air company, plus our educators on day 1, and day 3, day 10, and day 30. At day 14 and 30, we reviewed the protocol or the AGP profile and the pump report. Then we adjusted the medication or the protocol as needed. This is for all patients, and you can see here they started with, maybe it does not project well here, but they started with a time range of around 56%, and that's increased to 72% in 2 weeks and 73% in 1 month. So what we consider is good time and range in type 1 diabetes is above 70%. So they achieved very good result at 2 weeks and 1 month, 3 months, around 70%. Then it drifted slightly around 65% over the next 12 months. And you can see the number which completed 12 months, only 5 patients. So if we divide this to analyze the result based on the patient age, so you can see in adults, they started with time range 58%, and it increased to 73% or 74% in 2 weeks and 1 month, and that was maintained throughout the 12 months. In children, unfortunately, the one who completed like at least 3 months follow-up, only 2 patients. So we cannot really judge from this on the result on children, although you can see in the first 3 months they achieved a good result, but that was drifted down over the next 5 months to 51. And there one of them is what at outlier, with the A1, the time range went from 58 to 38 on follow-up. So I guess we need more patients, and this also underscore the importance of follow-up or support of these patients, especially children, in the first 1 year after installation of the pump. If we divide the patient was on MDI versus who were on pump before, we see the patient who is experienced on pump before, they have better result. So they achieved the time and range 70 to 75% in 2 weeks and 3 months, and that was maintained over the next 1 year. In patient who started with MDI, they achieved good result in the first 1 month, then their time range drift down in the next 12 months. But again, the sample size is only 2 patients who completed the 12 months, so we cannot really get a strong conclusion from this, but also underscore the importance of the patient support, especially during the first year of after pump installation, if they have no experience with the pump before. So I think this is the end of the experience with the hybrid closed loop system. Maybe we can take a couple of questions here before moving to the next presentation.
If you have any question, just raise your hand.
Okay. I guess just because we are also, I see a lot of obesity specialists here, I think the hybrid closed loop system is very good to get for patients with type 1 post-bariatric surgery because they have lots of fluctuation of blood sugar, and the hybrid closed loop system will be the best option for them if available in your institution. We have patient who has hypoglycemia unawareness and history of severe hypoglycemia, and it is really good in those patients because.
And you found that he's having hypoglycemia regardless of eating. He's not on high glycemic index food. He's compliant with low glycemic index foods, tried acarbose, etc. Because we have some of these cases in the Eastern Province.
Oh,
Would
you mean
be interested in
post-bariatric
seeing it?
surgery hypoglycemia?
Yes.
Okay.
Yeah. So he's had bypass. He's developing hypoglycemia quite frequently. And how would it help? It wouldn't help, right?
Sorry, what is that?
It wouldn't help them because basically it will only administer insulin. The pump.
We don't know. I think it will help.
How?
Because it is going to suspend the insulin infusion with hypoglycemia.
But they're not on insulin.
Oh, you
most
mean
of them.
in those without diabetes?
Because they're diabetic, you treated them and they're cured now, but they're going towards the other side in their procedures. And you give them
in type
acarbose,
2.
etc. So they
type
would not.
2. No,
Yeah.
I meant type 1.
Type
This
1,
patient
yeah.
in type 1 would be helpful
Would be
after
helpful.
bariatric surgery. Yeah.
Yeah.
But type 2 who are cured, usually we don't give a hybrid closed loop system to type 2 in general because they don't have the like the problem with the frequent hypoglycemia and hypoglycemia unawareness and other complications. Okay, so let's move to the next presentation. Don't know if you have it.
طيب دكتور محمد أنا عندي سؤال بما أننا ننتظر. Can we give the closed loop system for patients with type 2 diabetes who are complaining of insulin lack or insulin deficiency?
So there are studies done on type 2 who are insulin deficient, and it has been useful. Unfortunately, these are small studies. So in general, if you see most of the guidelines, they don't recommend insulin pump in type 2. But I think if they are insulin deficient, probably they're like type 1, and this would be a very good option for them, especially if they have frequent hypoglycemia and awareness, history of severe hypoglycemia on these things.
While the presentation is working, I want to just comment on Dr. Sani comment. Said if the patient on insulin pump and he has hypoglycemia, we are waiting for the bihormonal pump with the glucagon and insulin pump. Dr. Mehder, do you think it will helpful for them?
Theoretically, it might help if with glucagon, if they have hypoglycemia, and dual hormone insulin pump will give the patient a glucagon that will increase the blood sugar. But the problem is the lag of the CGM result. Because we know there is a lag between the interstitial fluid glucose level and the venous or the blood, the actual blood glucose level, and that delay may cause a problem, especially in those patients because they have like when they get post-bariatric hypoglycemia, their blood sugar is rapidly changing, and in those situations we know the CGM is not very accurate, and there will be a lag, and so this might complicate the issue, but we don't know unless we study that and see. But so far it is not available. The dual hormone insulin pump is not available and is not approved yet by the FDA. The last study was done in November, published in New England. The result was promising, but so far is not approved by FDA. And we have the future of diabetes presentation, maybe.
Dr. Mohammed, can I add a comment while they're preparing the presentation? Regarding the hypoglycemia event, I'm using the closed loop system for 6 months up to now. Last Ramadan was the first Ramadan since I was diagnosed with type 1 diabetes that I complete without يعني بدون ما أفطر يوم واحد. بفضل الله عز وجل ثم الكلوزد لوب لأنه يعني before hypoglycemia it will reduce the basal rate until the point it will stop the basal rate. So it will correct the hypoglycemia without any eating carbs. So for my experience, it will work. You will have less hypoglycemia.
It depends on the algorithm, of course. So this algorithm were studies on patient, like normal patient, not post-bariatric surgery patient. But theoretically it might, but that the complicating step is the lag between. So there should be an adjustment to the algorithm the pump are using to predict hypoglycemia, because they have algorithm which predict hypoglycemia in the next 30 minutes. So that's why the basal rate will change based on that. You do it or I do it? Okay, good. So I have no disclosure, except that I believe beta cell replacement therapy will be the cure for type 1 diabetes, and we might see this in the next maybe, I would predict in 3-5 years. So we have like crossed a lot of hurdles in our journey to cure type 1 diabetes. We finally see some light at the end of the tunnel, but still we have some challenges to go over. So I will go back to 2000 when this article in New England was published about islet cell transplant. So they published the result of 7 patients where they used steroid-free immune suppressive medication, and they achieved insulin independence in 7 patients with type 1 diabetes after islet transplant. After that, many centers tried, and the islet preparation went up. So the islet isolation starts with a cadaveric pancreas, and then they cannulate the pancreatic duct and inject collagenase enzyme to dissolve the exocrine part, which is 98% of the pancreas, and we need only that 2% of the islet from the pancreas, where it is now centrifuged in Ricordi chamber, then purified and sent to the angio suite to be given in the portal vein. So they catheterize the portal vein percutaneously, then inject the islet infusion in the portal vein, then the islet itself goes to the liver, and it is stuck there in the liver, start to establish blood supply and produce insulin. So now the result of the islet is improving. So this is the pancreas transplant alone, and we can see the insulin independence rate over the years. And this is the islet transplant alone. Again, there is a short, studied for a shorter period of time. But again, we are close now to the pancreas transplant alone result. This is a patient who you can see had type 1 diabetes with undetectable C-peptide, underwent a transplant, and you can see the tracing of the CGM, which went back to below 100 all the time. So you will never see a result like this except with islet or pancreas transplant. This is a patient of mine where I treated. She had type 1 diabetes for a long time, since the age of 3 years. She had severe hypoglycemia severe hypoglycemic episodes more than 10 times per week, including 1 to 2 times per week. If you imagine, 1 to 2 times per week, she required glucagon administration by her husband. This is really, it was debilitating for her. She was like homebound all the time. She doesn't go out, and this was her tracing. And she had islet transplant, 3 infusion in 2003, 2008, and 2014. You can see her CGM tracing before and after, 9 months after the first islet transplant. This is her A1C, and you can see it was maintained below 7% all the time with the 3 infusion. She had no hypoglycemia since the first transplant, and she required sometimes like intermittently insulin insulin treatment until the last infusion, where she did not require any. So I have been following her for more than 15 years, and she is now insulin-free since her last transplant in 2014. We also, there are some studies which showed that we can maintain this good result over many years, and you can see this article, and we achieved good result even after 10 years of the islet transplant, with time range is over 80%. Islet transplant finally recognized by the last guidelines, and they put it there as for patients who had other organ transplant and they have problem with diabetes, or if they have type 1 diabetes and struggling with hypoglycemia, recurrent hypoglycemia and awareness, or severe hypoglycemia. So the challenge with the islet was what is the supply. So we are short of supply of pancreas organs, especially that to achieve insulin independence, you need at least two organs or maybe 3 organs sometimes. So there was a search for an alternative source of beta cells, and stem cells was the ultimate solution. And from stem cells, we are able now to produce beta cells, which can be used for stem cell therapy or disease modeling to study, for example, drugs or pathophysiology, and also for gene editing to prevent the immune attack on the cells. So there have been many trials on stem cell. Just for sake of time, I will skip some of them. So this is the phase 1-2 trials, which was tried in Edmonton, and they tried to overcome the immune attack on stem cells by encapsulating them in or putting them in a major capsule. But the problem, these capsules prevented the immune attack, but subhanallah, the body tried now to isolate these capsules by forming a fibrous tissue around them, which prevent blood and oxygen, and eventually these cells died. But at least when they extracted them, they found that these stem cells matured to beta or insulin producing cells. So they did phase 2 trial, where they did holes in these capsules to allow the blood vessels to go inside. But unfortunately, because they allowed the blood vessel to go inside, now these cells are attacked by the immune system, so they have to give immune suppressive medication to the patient. And we have worked with the Vancouver group, and I worked particularly on this phase 2 trial, and we have published some result which showed particularly they are safe and well tolerated. The insulin cells were surviving and maturing to beta cells, and they were able to produce C-peptide. There was a 20% reduction in insulin requirement, and the patient spent 13% more time in range, and their A1C was always below 7%, and they were protected from hypoglycemia, even if they have hypoglycemia and awareness. The same was replicated in Europe, and Europe started late in 2020. We started in 2018. Now they are preparing for phase 2 and 3 trials using immune suppressive free protocols and with gene editing. So they edited these stem cells so to make them basically like unrecognizable to our immune system. There is also another group in Europe where they developed mature B cells from stem cells, and they did exactly what we did in islet cell transplant. So they purified these or reduced beta cells from the stem cells, and they injected them in the portal vein like what we do with the islet. And they so far reported 3 patients, and the first patient was insulin-free, and his pre-operative dose was 34. Time in range went to almost 100%, and A1C went down from 8.6% to 5.2. The other 2, they were only on the 90 and 29 days, so it was too early to judge the result. So this is like the future of beta cell replacement. So I expect in the next couple of years more result on these studies, and probably we will achieve cure for diabetes. Nevertheless, with immune suppressive medication, hopefully in the future we will see more studies on gene editing and like the protocols with no immune suppression, and I'm sure we will reach a solution for those problems. The other part of diabetes future is technology, of course, although I consider stem cell as a technology. So there are some innovation in devices, telehealth, digital data and incorporation of them to the health electronic records. There is a qualitative hypoglycemia alarms, artificial intelligence, cybersecurity of diabetes devices, which is a big thing now, and diabetes technology registry. So I'm talking now, we'll talk about the insulin delivery system and sensing technology. So we can see here we started on the left-hand side with sensor-augmented pump in 2006, where the pump can be used with a sensor. In 2009, we invented the suspend on low insulin pump. So the insulin pump will suspend the insulin delivery when the patient is in hypoglycemia. In 2015, we advanced to suspend before low, what Dr. Hassan talked about. So the insulin pump is able to predict that the patient will go in hypoglycemia in the next 30 minutes, then the pump will suspend even before the patient goes in hypoglycemia. In 2017, we started to use the hybrid closed loop system, which can do suspend and low, and we can adjust also the basal rate to increase in case of hyperglycemia. And nowadays we have the advanced hybrid closed loop system where it can, in addition to the adjustment of the basal rate, it can give auto-correction boluses to the patient if the blood sugar is predicted to be high. So we are very close to the artificial pancreas. These are the ones which is available now in the market. We have CAM APS system. This is available in Europe and particularly in United Kingdom. We don't have it yet. We have here Medtronic 780G and 670, and we have the Tandem Control IQ. There is also another one called Medtram TouchCare Nano, which is not available yet in the kingdom. There is also some other systems which is available outside, the Diaby Loop system, hybrid closed loop system, and the Omnipod Horizon or Omnipod 5, which is again a hybrid closed loop system. We have here Omnipod Dash, which is I would call it an insulin delivery system, but it is not a hybrid closed loop system because it cannot connect or communicate with a sensor yet. But the Omnipod Horizon or Omnipod 5 can communicate with the sensor and can be advanced to a hybrid closed loop system, but it is not available yet except in the United States. The bionic pancreas is a dual hormone pump where there's insulin and glucagon, and this is set based only the weight. So we need nothing except the patient weight. We just put the patient weight, then the system will figure out how to operate, and they will give the basal or the continuous pump or the basal control. Plus, also will give boluses for meals, but the patient need to announce when they are eating. So the patient just press a button that I'm going to have my lunch now, then that will help the pump to give the bolus. And this is the study I quote, which was published last year in New England, and you can see they achieved a better result than the standard of care, and you can see here the time in range is much improved, particularly overnight when the patient is sleeping, and we can understand that because the patient is not eating, and we can achieve good result. As you can see here, the standard of care on the baseline, the A1C was 7.9, and it was done with the bionic pancreas, it went down to 7.3, and there was no change in the standard of care. There is also, please let me know if I am over time. So insulin delivery system also improved in the infusion sets. So now the current infusion sets for pumps only last for 3 days. Now we have an infusion set which lasts for 7 days, which help the patient and make their life much easier. There is also improvement in the sensing technology. For example, in the Guardian 3 now, we have Guardian 4 sensor. In Guardian 3, the patient needs to calibrate at least 2 times a day. In Guardian 4, they don't need to calibrate at all, and the accuracy of the sensing technology is better. We have also the Dexcom G7. We have currently in the kingdom Dexcom G6. So the next generation is called Dexcom G7, and so the size is much less, 60% less. There is shorter warm-up time for 30 minutes only, and it is more accurate. We have Libre 2, probably you know on the market now, and Libre 3 is coming soon, and it's available in some countries in Europe. So Libre 2 is a flash. We call it a flash or intermittently scanned. So the patient need to scan the sensor to get the result. But in Libre 3, they do not need to scan. The Libre 3 will send the number to the machine or to the application directly. There is also some sensing technology in the future called Synergy, where they combine the transmitter and the sensor itself, and they decrease the size, and also they decrease the time for inserting the sensor. You can see on your left or your right-hand side, it takes 9 seconds for the new one, while it takes 120 1 minute 20 seconds for the old sensor. خلاص time? Okay, I'll stop here. It's difficult to cover all the future of diabetes in 15 minutes, but I think I gave you the most important ones. And thank you very much for your attention.
Thank you so much, Dr. Mohammed.
Can we take questions now?
We will take it at the end.
I might leave.
خلاص مو مشكلة. We'll take 1 to 2 questions.
Thank you for this amazing development in treatment of diabetes. Although I'm not I'm an endocrinologist, but would other hormones help on decreasing the needs for insulin, like the Saxenda, the Ozempic, the Mounjaro. Would those new injectable drugs help decreasing the insulin requirements so the hypoglycemia will be prevented? Has this been practiced?
Oh, yeah, so we call this like adjunctive treatment for type 1 diabetes, and many things were tried. Some of them the GLP-1 receptor agonists. There are studies on liraglutide. There are studies on semaglutide. There are studies also on SGLT2 inhibitors, metformin, DPP-4 inhibitors. So many things were tried. Nothing really is approved for use in type 1 diabetes. The one which was only approved by European agency is dapagliflozin, but the company voluntarily withdraw that indication. So these can be used. I use it in some patients, especially sometimes in obese type 1 patient. I use a GLP-1 receptor agonist. However, there is, as they say, no free ride. So there are some concerns when you use this adjunctive treatment. One of them is the risk of hypoglycemia increase. The other one is the risk of DKA increase. So when you start this treatment, particularly SGLT2 or GLP-1, you make sure the patient really is aware of the side effect, the potential risk, and they are really educated how to prevent DKA and how to prevent hypoglycemia. Unless the patient is really educated, they check frequently, they have ketone strips at home to use, I don't start adjunctive treatment. If the patient is well educated and they follow the instructions and they are very diligent in checking blood sugar, checking ketones when needed, then these can be tried. But off-label, of course. Nothing really is indicated, or nothing really is approved by any authorizing agency.
But type 2 diabetes, it is used.
Type 2 is, of course, yeah, it is approved, yeah. For SGLT2 inhibitor, GLP-1 receptor agonist is approved.
Thank you.
Very informative presentation. And we'll call the second presenter, Dr. Osama الصانع, bariatric. The second presenter, the very experienced senior surgeon, Dr. Osama الصانع, will present ERAS in bariatric surgery. It's a very interesting topic for the bariatric surgeon, how to have enhanced recovery in bariatric surgery.
Thank you for the privilege of the podium, and thank you for the invitation. It's interesting to find a mixed group of probably all specialties. I hope there is somebody from anesthesia. I'm not sure if there is any anesthesiologists who attended today. I think anesthesia started ERAS with the blessings of surgeons. And I looked at ERAS from a different perspective other than just enhanced recovery after bariatric surgery. Basically, ERAS, the name indicates that you're improving the recovery of the patient. But in reality, it's just simply another type of guideline. It's a guideline in bariatric surgery. And what I wanted to share with you today is, because I don't have the presentation, I have it on the screen, I'll just stand a little bit to the side. Okay, so I'll use the other one, probably. Use one of these two, probably will work. Can you put, is it on play? Okay. You're moving, huh? I'll ask you to move it. Okay, thank you, sorry. Next. So basically, it's protocols that encourage early adoption of new innovation and knowledge in surgical practice. So you all know that today we try to avoid keeping a patient MPO, or putting an NG tube, or putting a drain in patients. So basically, ERAS tries to defy what we hold sacred for many years, where we felt we cannot have a patient who had gastric surgery without having an NG tube inside his nose. We cannot leave a patient who had a cholecystectomy without leaving a drain. So it was all dictum, and now we're trying to break away from this dictum. Next. So basically, it's a guideline. So how are guidelines written? Oh, sorry. Okay, so how are guidelines written matters, because you're going to adopt these guidelines, and those guidelines may affect you in the way you will practice. So, for example, ERA started the guidelines in bariatric surgery in 2016. Then in 2020, they became outdated, so they had to do them again. Now it's time for a new update as well. You've seen now Dr. Ahmed Al-Ghamdi presented his presentation on basically the new guidelines, where bariatric surgery has transformed the guidelines. Next, please. So how are guidelines written in ERAS? In particular, in ERAS basically went and looked at all the database that exists around articles surrounding enhanced recovery. Then they basically studied the evidence up to 2020 and ranked it. So a study that is high-level evidence, intermediate-level evidence, or low-level evidence. Then they took those studies and put them in what is called the grade system. And I advise anybody who is interested in research, who is interested in developing guidelines, who really works on academics, to familiarize himself with the term grade. And grade is basically invented by Goyer in 2008, and since 2008 it has become most of the societies would use grade to develop guidelines or recommendations. So we'll see how that is done. So basically, you go in, you evaluate all the evidence, you come up with what is called grading of the evidence. After you grade all the evidence, then you come up with this information. You give it to the doctor, who is I call them the end user of this data, and you say, okay, can you make a decision how you want to practice based on all this evidence? So I'm going to go over it and show you, because you're trying to reach a consensus based on conflicting evidence, more or less. Next. So what is a grade system? Grading system is basically grade of recommendations, assessment, development, and evaluation. So what does it say? It says that we're not going to go by evidence per se. So, for example, the quality of the evidence can be high level, then we probably would want to make a strong recommendation if the evidence is strong. On low evidence or moderate evidence, we'd like to make a weak recommendation. And I'll give you an example of what is a strong recommendation now, is operating on a patient with type 2 diabetes and doing bariatric surgery. I think it's a strong recommendation, and there is enough evidence. So where is the evidence? The evidence example is in the STAMPEDE trial, which is a multicentric trial, a level 1 evidence, or you may call it a high-level evidence, and there are about 8 or 9 trials done thus far, and there are multi-systematic reviews, including of the largest database in the US, that showed evidence for it. But also, that shouldn't be the only reason. Why? Because you have to balance the desired versus the undesired effect. If I tell you, I will definitely hit this wall and penetrate it by a gun in order to kill a fly, yes, I can. But what is the damage that is happening? So we have to look at desired versus undesired effect. So the fact that I say, well, bypass will definitely cure a diabetic patient more than a sleeve, but at what cost? So desired and undesired should be weighed. So that is the second one. So if there is a difference clear, then you'll go for a strong recommendation. But if the difference is subtle, then you don't want to go do a strong recommendation. Third thing is value and preference. If it goes against your belief system, for example, it's very difficult for us to make a recommendation, in the Western countries about cessation of alcohol. Yes, we may talk about alcohol abuse, or basically somebody becoming addicted to alcohol or dependent. But we cannot say anything against it because the society would not agree. But in an Islamic country, you probably could say that and say, well, we will work on cessation of alcohol use, for example. So preference in the society matters. Also, if I want to make a recommendation that will be very costly, then it's a problem. I'll give you an example. I volunteer at the Dammam Central Hospital to teach the doctors over there, and one of the problems they have is they cannot operate on a patient for bariatrics except 9 months later or a year later. And when I asked them, I said, why? I said, because we need to do endoscopy. The endoscopists are very busy, and we have to do it routine. And I asked them, I said, how many times you've attended the endoscopy? None. Do you know about the endoscopy's results? Yeah, we look at the report. Okay, so I asked them, said, today 3 cases were done. Any of you read the report? None. So basically it became a routine. So routine endoscopy, costly, and then did it change your practice? No, it didn't change our practice. So why do it? And then if you look at the evidence, and you say, well, the evidence is strong, I'd say, well, let's look at the evidence, and you'll find that pre-op routine endoscopy, it has no evidence. So this was the screen is back. Okay. So this was an issue that needs to be discussed, whether you become selective or non-selective in terms of the recommendation. Okay. So this is the most accepted type of developing guidelines nowadays. Next slide, please. Okay. So why guidelines matter? Because you can deny somebody the care. For example, in Saudi, when we established the guidelines that below 45 cannot have surgery by the Insurance Council, we denied many patients who anywhere in the world would have had bariatric surgery, except in Saudi. And then, when we said to patients, the only approved procedure is a sleeve, you get a patient with severe reflux and you say, I'll still do a sleeve for you. So you would subject him to risk because of the guidelines. Because the guidelines said in private practice, the only procedure approved thus far was a sleeve. So we had to go and defend ourselves against these guidelines and change them. And the SAS MBS worked hard to change those guidelines, and we have to give them credit for it, but there is a lot to be done. Okay, so I'll ask you something also. In the US, do you know that until recently, only band could be done for a BMI below 35? And you know what is the damage caused by the band lifelong on patients? Okay. Now, question to the audience, because you asked us today about type 1 diabetes, etc. So who of us today has used a grade-based recommendation on the type of bariatric surgery in a diabetic for a particular patient? You will find that all of us have some form of algorithm in our brain, and we would defend it definitely, but there is bias when the patient comes to you and says, so doctor, which procedure should I have? What is the chance of me curing? Can I have a sleeve? And if you're more inclined to do a mini bypass or an RY bypass, you would probably flavor it in a way to tell him that this is what you would do. Okay, so there are scores, and we will, inshallah, next year we'll issue a paper on that. We have had enough data now for about 3,000 cases that we are reviewing, and we're showing why the scores fail to really advise people on what to do, because a lot of people now, they have made apps. And they should say, well, in your clinic, please, just put the patient information in the app, and you'll tell him what procedure to have. But we don't agree with this scoring system. So that is an issue to be content with. Next. Okay, so I'll give you an example of the grading system, how it works in general. So VTE, thromboprophylaxis against venous thromboembolism. Most of us in bariatric surgery dread bleeding. And we say, okay, we're going to operate, so when should I give Glexane? Pre-op? Post-op? Should I give it the day before? And for how many days should I give it? What is the dose? In fact, we know that they're not, what we call them, they're the unmonitored anticoagulation. They're not like warfarin and heparin when we used to measure PT, PDT and all that. No, here we're giving it blindly. And yes, there are factors, there are studies. You can do activated factor 10, but how many hospitals have activated factor 10 assays? It's very difficult. And is there any literature knowledge about it? No, there is no literature knowledge about it, of what is a therapeutic dose. Is therapeutic worthwhile to prevent venous thromboembolism? We don't know. So a lot of misinformation, and we have to make a decision. And let me tell you, so some smart guy looked at the data and said, well, the incidence of PE is 0.3%. We know now. 0.3, in fact, it's VTE. So 0.1 is PE, 0.2 is DVT, combined is 0.3. And then he said, that is the incidence in bariatric surgery if you use sequential compressive devices, the veno boots or the pneumatic boots that the patient use. So it's 3 in 1,000 cases. So you're trying to give them prophylaxis to prevent 3 cases of PE. Okay, let's imagine out of 1,000. And then the question was posed to people, and they were asked. There were 63 physicians and 61 patients. And they asked them, how many bleeding would you accept if I told you I have to prevent those 3? Because we are the surgeons, we didn't like bleeding, so we went to what, 0.1 to 0.3, said I don't accept more than 0.3% bleeding. The patients were more lenient accepting bleeding. They went to 2.2%, said we will accept 2.2% bleeding when they came and looked at the data. So how did we work this together? I was one of the people who looked at the data, and I said, if it was me, I would say the following. I'd say strong recommendation in high-risk patients. It shouldn't be in all patients. Sequential compressive devices should be in all patients. So a hospital who doesn't have sequential compressive devices must go and buy them rather than buy Glixane. Okay, so it is shocking for me, I'm sorry about the misspelling, that SAS MBS is the only society that issued strong recommendation to use in all patients. None of the other societies in the world have issued this. We're the only society. So this is one of the other projects that I'm working with my fellows, trying to produce data to tell people what to do. So we're working hard on collecting our data and going over it. Next slide, please. So how guidelines are developed? So I told you, you have 4 criteria. But in reality, in order to develop a single guideline, I'll tell you how long it takes. First, you formulate a guidance development group. So for example, for VTE, you'd say, I'll develop a group to discuss the type of prophylaxis, the timing, the duration, and who should be in that committee. You probably bring surgeons, anesthesia, you have to bring internal medicine, hematology, and pharmacy. Because we're blinded and we're biased. We have to bring other people in to help us because they're the expert in that subject matter. Next. So step 2 is you have to decide on the approach. What is your approach? So my approach is basically I have to look at mechanical versus chemical, or for example, mechanical versus chemical plus mechanical. It makes a difference. So you have to make a decision. What are you looking for? Are you going to consider even without mechanical in cost-cutting days? Okay. And then you discuss all the issues, timing, pre-op versus on-table versus post-op, primary or versus revisional case should they get, patients hypercoagulable, high BMI, low BMI, does it matter? And you will find that there is enough literature, secondary data, not primary data, and it's so conflicting all over the place. And the problem is many of the studies in the medical field, and I'll tell you this as a secret, in the medical field, they're more cognizant of the quality of the data and they would not publish easily. In the surgical field, everybody can publish. And it passes easily. If you look at most of our literature, it's worthless in the surgical journals. Next, please.
Sorry, Dr. Osama, to interrupt, but you have 2 minutes left.
Only? Okay, I haven't started, but I'll give you the guidelines. So anyway, so you look at literature search, okay, because I was told 15 minutes. So how is 15 minutes?
No, 14 minutes.
Well, really?
Yeah.
Okay, fine, okay. So you look at the databases. Next slide, please. And then you rank the evidence. Next slide, please. And then you do an independent expert review, so you have an outside reviewer for you. This is the most important part of the lecture, I think. And then next, please. And then you issue what I call Delphi process. You put everybody together, you make them do a consensus by circulating questionnaires of patient scenarios until you find an agreement on what is the protocol. This takes, I started doing guidelines in 1996. And we did one guideline on do we do adrenalectomy on 3 centimeter or not. We spent 9 months until we reach one guideline. Please go ahead next. هتعطيني 2 minutes زيادة? Next slide, please. Okay, so I broke the guidelines in 2010. I was telling Ahmed I broke the guidelines. This lady came to me with eclampsia. And her IVF specialist said, Osama, you have to do her. And I went and I discussed with my colleagues, etc., and the internists, and I signed everybody on it, and I did her. And she called her son on my name, and now she has 3 kids. And though she is not severely obese, she had extreme insulin resistance that caused her to develop eclampsia. I had this kid who had BMI of 33, a kidney transplant, and he had to go. He said, I lost my kidney. I don't want to lose my kidney again. And we did the RYGP, and until today, he has his kidney. Next, please. So how did we develop ERAS? I'll tell you. So we said, we are going to take the society as is. We're not going to invent the wheel. We'll take the society guidelines. Next slide, please. We sat on a product. I gave the team all the tasks. Next. Assigned everybody a responsibility. Next. They said there is a pre-hospital component, a pre-anesthesia component, a pre-op component, and an intra-operative component. Next. Then we have an intra-op, PACU, day surgery, discharge. So it spans the whole journey of a patient. And we gave particular interest to pre-operative analgesia and anticoagulation prophylaxis. That is something that is not really in detail. Next. So, and then we issued an ERAS booklet to teach patients what is ERAS. Okay. And then next. And then we issued a report. We issued an annual report every year of what we did. What are the results? How we work on it. And we did, in fact, we issued 3 randomized controlled trials on ERAS, and we are working on our 4th randomized controlled trial. Next. Okay, so these are the guidelines. Now the lecture is the boring part, but I'm going to skip it. I'll just show you a few slides. Okay, so the guidelines was issued in 2021. Next. Next, please. So basically, the first guideline tells you have to give patient information. So what is information? Today, in this day and age, you have to make it virtual because you don't have time. Most of you don't have time. And you have busy clinics. So I often give the patient the link and say, go look at it. Here's the information available. And then I want to show you, on each guideline, what did the society put? It put the level of the evidence and the recommendation grade. And you'll find they don't correlate. Even there is low-level evidence, but it is a strong recommendation. Why? Because there is no undesired effect. It's all a desired. Information is good. Next. And if you look at the issue of BMI, BMI was invented in 1991, and people don't know. It was an exclusion guideline. It was written to tell you don't operate on anybody below 40 or below 35 with comorbidities. It wasn't written to say who's eligible. It said those are ineligible. The others we don't know. And then we worked hard, we switched it to eligible criteria. And 2021, Ahmed mentioned it. Please, next slide. And then, like I told you about smoking and non-smoking, the issue is we have to be familiar with the knowledge. And part of the knowledge is if you operate on somebody who's alcohol dependent or has alcoholism, if you operate on him and he goes back to alcoholism, they develop cirrhosis much earlier than if you didn't operate on them. So hence, you may want to deny them. Next. We talked about approval and disapproval. So basically, the point that we need to say is that if you want to do perioperative weight loss, be careful whom you subject to perioperative weight loss, because if you give them a very low-calorie diet and he's diabetic, you may end up hypoglycemic. So watch that. Next. And also watch that you may cause him disapproval because his weight will drop below 40 if he's in the government, or below 45, and then you deny him care. Rehab, it's written in the guidelines, and we went against it, and we wrote a paper about it. We said the patients who need rehab are the ones who cannot move. Operate on them and then do the rehab. That is what we think is feasible. Next. Nausea and vomiting took a lot of care. It's important. And a lot of talk is about dexamethasone and using it. We have the pioneers of ERAS say give up to 16. We're giving only 8. Next. Okay. Important, we talk about carb loading, and I say there is no evidence, it's low-level evidence, but the problem is in diabetics, watch out, don't give it. So they think it helps recovery, but watch out in diabetics. Next. Okay. All our decisions are on early tolerance, sending patients home, making their recovery better. So what is bothering a patient who had a sleep? Nausea and vomiting, and the pain. So if you cure their nausea and vomiting earlier than the others, then you've achieved ERAS. So basically, all your target is making sure that this patient doesn't develop nausea and vomiting post-op. And we work on the algorithms and the methodology and multiple medications, etc. We change anesthesia to suit it, to reduce it. So a lot of action is done to prevent this. And I'll tell you, the one thing that we need to be careful about is sometimes make sure that it's not food intolerance and the patient's sleeve is twisted or something, and you're trying to prevent nausea and vomiting. So make sure the surgically you pick it up. Next. And fluid therapy, it's important. Why is it important? Because in the OR, you'd say, please, you talk to the anesthesia, say, give him fluids, give him fluids. I often say, don't interfere in anesthesia. Tell them, what do you think is the problem? Don't tell them what to do. Because quite often, Overhydration is a problem. They have to decide whether they need inotropes or they need fluids. And it can be done scientifically. You can do what they call, next slide please, I'll show you. So the anesthesiologists, they took a long journey. They started, this is a chemodectoma being done in Mass General in 1846. They started with ether. Next. And then discovered the effect of ether. Next. And then Queen Victoria had her first delivery with handkerchief with chloroform. Next. And then we came with the inhalational drugs. Those inhalational drugs cause nausea, vomiting. So we have to balance it. So how do we balance it? Next. And then we discovered that morphine, which was a cough syrup initially, that it has narcotic effect. So now we have narcotics and we have inhalational. Next. And then we discovered synthetic opioids, which are basically fentanyl and what have you. Next. And then we discovered that we have hypnotics, like propofol, like all these medications. So now we have all these medications. So how do we construct it? You have to construct it with the idea that you want to send patients early home. Next. So basically, we worked around it. So we said we're going to reduce opioid consumption based on a multimodality approach. Next. So this is our paper on multimodality approach. We demonstrated opioid-free is better. Next. And we show here the results. Next. And here is the effect on their tolerance of oral intake. It improved when we reduced opioids. Next. And then we have to look at regional anesthesia. So not only general, we started. People don't know that Sigmund Freud discovered local anesthesia. Next. And so here's a tab block. So in every case, we have an ultrasound, we do a tab block in every case in our hospital. Next. There are 3 types of tab blocks. I don't want to go into them. If you ask me after the lecture, I'll tell you. Here is the issue. Anesthesia, you give all these medications, you don't want the patient to have a wakeful experience. You can measure ETAG, which is end-tidal anesthetic gas, or you can measure the bispectral index. But you need to have the patient deep in surgery. You don't want to have a wakeful experience. Next. And the most difficult is the airway, the risky. Deaths have happened because of airway in bariatric patients, and we need to be cognizant of that. You don't want to have a patient of that. So the unanticipated are the most difficult. And here, next, please. Skip it. I don't want to show the fiber optic intubation. Skip it. Okay. So basically, started with the AT tube. Today, until today, we still use the AT tubes. Next. And then we developed fiber optic scoping. You should have it in your OR. If you're doing a bariatrics, you should have familiarity with doing fiber optic intubation, awake intubation. Next. Positive pressure ventilation is important. Today, we don't really think about it, but in the olden days, they used to put the patient in a vacuum so he can breathe because they were afraid of barotrauma. Today, when you operate, you're doing positive pressure. And if you're doing a hiatal hernia and you've injured, you may cause a pneumothorax, tension pneumothorax, so you have to be watchful of that. Next. Pressure control and volume control are acceptable in bariatric patients. So you see the guidelines are very detailed on ventilation. But what is important next is basically neuromuscular blockade. I judge the case on the field, how easy it is to operate by the neuromuscular blockade. I often give them a grade, the anesthesia. I say, I'm relaxed, I'm operating well, or I'm struggling. So you often have to look at that, and you have to understand what did he use. And the risk of that is that when a patient, you cannot intubate and you give neuromuscular blockade, it's a problem. So you have to ask them, say, well, do we have Sugamedics, for example? So if there is a problem, we can reverse. Even if we don't have, we'll do rapid sequence ventilation, intubation with the sucks. Next.
Sorry, Dr. Sam, but we reached 25 minutes.
Okay, you give me 2 minutes, وخلص لك. خلص وعد. Okay. Laparoscopy, because this is laparoscopy. It started 1910. Next. All this tells you why we took time. Why we took time? Because things develop like they showed you today, the pumps. With time, we keep on developing the equipment. And then procedures develop based on developing the equipment, not vice versa. Next. And this is why Star Wars was done, the first trilogy. The second trilogy happened 16 years later. Why? Because they waited for the computers to develop. Next. So initially, we only had non-bariatric procedures because our equipment wasn't sufficient. Next. Then we developed the staples based on a Russian invention. And then we took over. And since the staples were invented, then the next slide, we did bypass. Those two are the ones who trained me on the left, and they are open surgeons. So when laparoscopy developed, they couldn't do the staples, and they retired. And the guy on the right is the one who trained me afterwards. He was a laparoscopic surgeon. Next. This is the guy who invented RYGB. He could not do it before having the staples. So I think you have to be innovative, and part of innovation is to think what is next to be done based on the new technology that will develop. I don't think it's bypass and sleeve. I think it's something else. Next. So at the end, the volume is important, but I will tell you one thing. Seniors must help juniors, because you don't want them to pass through what we passed through. We struggled initially to develop the technology because there was nobody to train us. We don't wish it upon you. Next. And then, please don't use NG tubes. Don't use drains unless you have to. Next. We're almost done. And then make sure the obstructive sleep apnea doesn't have to go to the ICU. Don't cancel your cases for it. They can be treated on the floor. Next. And then thromboprophylaxis, I already went through it. I was going to show you some of our data, but I'll leave it to another talk. Next. This is our nausea and vomiting reduction in our protocols. This is our second randomized control trial. Next. And then nutritional care. It's important. The next slide, I want to show the importance of the next slide. Next. Thiamine deficiency. I've seen Wernicke's encephalopathy in patients who could not drink, and their surgeon kept on pushing them. Yes, you can push them waiting until they recover, but be careful, because when they develop thiamine deficiency, they'll have hallucination, delusion, delirium, and then it becomes an acute emergency. So watch out for thiamine deficiency. Next. Our protocol, we do blood work. Don't just not do blood work. Do blood work for patients. Please watch them. They will develop deficiency, and then you regret it. Final. Next. PPI prophylaxis, there is no real evidence for it in sleeve. There is in bypass. But I think you understand that sleeve is more reflexogenic because of the technique we do. So improve your technique. That will reduce it. Next. Gallstones, in RGB, there is enough evidence to use it, but if you ask me, say, how many of your patients are using it? I asked all my patients, and I came up with only 2% were compliant when we gave it to them. Next. And hence we stopped giving it. I think that's the last slide. I was going to show the ERAS protocol in our hospital, but I think it's a video, so we'll skip that. Thank you.
Thank you, Doctor. We will not take questions but I have to give the final comment. Thank you for coming and presenting Dr. Osama Al-Sani at this presentation. He's pioneer for ERAS, and I think I will keep this recommendation, Dr. Abdullah Sahimi. We have a 25 center in Amwaj. I hope all our center will go with ERAS. It reduces the length of stay, it reduces the cost. And we are working all the centers in Amwaj to go with ERAS. That's why I bring him, and thanks for him. He came and he bring this one. And we'll keep it on one of our recommendations in the end of this session and this conference. Thank you very much.
Now I will present Dr. Khalid Qulasi. He will present the new perspective of healthcare transformation of diabetes on diabetes management. Welcome, Dr. Khalid.
Bismillah ar-Rahman ar-Rahim. Thank you, Chairman. Thank you all. And I wish I had to have sometimes like Dr. Sana. This is the new concept about the transformation. Let's go a slide. As we know about the vision of Saudi Arabia 2030, a lot of health sectors comes here, and we are thinking about how to implementing health transformation as a new prospectively, particularly in diabetic patients. So my outlines here, usually I will try to finish it within 15 minutes. We are talking about the transformation, why we need to do transformations, and what is the prevalence of the diabetes. We're going to talk about the experience of health third clusters and perspective of healthcare with the value-based healthcare and the triple aim and new concept about the IPU. So the question here, why we need to have some transformation? As we know, the population of the kingdom usually is going up within time to time, and the result here is shown that there is grew about the patient population reaching from 33.5 million to 39.5 million, actually expecting from 2018 till to 2030, and the number of elderly actually is going up actually from age of 60 to 79 from 1.9 millions to 4.6 millions. This is not at the end of the story. Actually, we are having a burden how to deliver the treatment for our population. We found that primary care remain inadequate with inconsistent, and also there is a burden in the hospital as a secondary care, tertiary care, associating with poorly distributing among the kingdom. And also at that time, we found there is a significant gaps in the quality of care regarding the patients. Although regarding the protocols, there is a lack of the concept about the protocols and the pathway for the treatment, and also there is the three types of the treatment usually comes here with staff-centric approach rather than patient-centric approach. So let's have a look here about the patients with obesity, and although the majority of them they presented with the diabetes, we found that class 1 obesity usually comes here at the kingdom in the last 2017 with the 4.1 millions, and the class 2 usually comes here with 2.1, and the class 3 more than or close to 1 million. And this is not the end of the story. We found that there is a growing from that obesity with the class 1, it's going to class 2, class 3, and this is etc. And this comes with 35% of total populations. And worldwide, the Saudi Arabia, that's showing that obesity with the ranking across the world usually ranks around the number of 18th worldwide. Let's have a look here about why we need treated patients whenever they are obese patients or they are diabetic patients. We found that, as we know, this is a common scenario here, the patients who are having healthy weight, overweight, obesity, and severe obesity. What is the implication about the life expectancy? We found that this is a study, and it was come here with the retrospectively, shown that if you are overweight, you're having a chance about the 40% to having high mortality rate regarding ischemic heart disease or stroke, etc. While if you have stage 1 to stage 2 obesity, usually having life expectancy to be reduced by 3 years, and sometimes if you have stage 3 obesity and above, you have life expectancy to be reduced from 8 to 10 years. This is actually the estimating number about prevalence. We took it from CNHI in Saudi population, especially in our area in Riyadh cluster 3. It's showing that the commonest diseases that we have comes here with the obesity and diabetes. And this is the map of our hospital. We have 14 hospitals, and we have 154 PHCs, and usually comes from the Riyadh to Afif, more than 600 kilometers. And this is the challenging, this is the difficulties. We need to catching our population, we need to reach of them, we need to ask ourselves how many percentage of them do you presented with the diabetes, how are we going to have access of care, because it's a rural area, it's coming with difficulties as well. And once what we did here, we passed through to active registration first to know what we have here, and we're reaching around from 1.4 million that we have in our area, 441 patients already they presented with active registration. And we comes here to show that the types of diabetes, although the study is still still growing, but we showed that from age of day 1 until to 7 and above, we're giving the prevalence of diabetes, so what we can do the next types for treatment. So let's talk about the perspective in healthcare transformation, what we need to do. As I mentioned by Dr. Asani and other colleagues, that we need, once to deliver the knowledge, you need to deliver the treatment based on evidence-based medicine. And this is actually wide common practice. For example, if you would like to having controlling of morning hyperglycemia, just to starting with basal insulin. Secondly, we're talking about the value-based healthcare. So this is the new concept of healthcare that you need to put your patients to giving highly clinical outcome with decreasing of the cost, of the burden of the cost. And this is the example we shown here, as I mentioned by other colleagues, about the insulin sensors and how we delivered. This is the beauty of this. We're teaching our patients how they controlling their blood sugar and at the same time just to prevent complication, to bring them directly to the hospital. Third things that we have is that called the triple aim. The triple aim, usually we are thinking about the patient-centric approach. So we think about the clinical outcome, we're talking about the financial outcome, and at the same time we're talking about the patient-centric and all over the patient satisfaction. Right now and right days, all the patients, they need to categorizing regarding the satisfaction because it's one of the most important in transformation as well. So let's give an example. What is the triple aim we can deliver for our patient? I need to decrease the cost. I need to prevent a complication. Simply, I need to give also patient satisfaction to give as a once daily injection and at the same time to be as a patient-centric approach. They wish to decreasing their weight or they wish to have a good control like this, an example for other particular medication. The fourth one is appropriate care. The appropriate care usually comes here with the specific condition for specific populations based on the study. As I mentioned by Dr. Al-Midhil, for islet cell transplant or insulin pump, this is the good example for appropriate care. So let's talk about the patient journey lives and the diabetes care cycles, what we need to do and what we have to have. So let's go from the beginning. Our health status is going down with day to day. So we have here as short-term plan and long-term plan. We need to catching area of lifestyle modifications and at the same time to having the prevention and the screening from the beginning. You need to having sustainability of the treatment. You need to avoid of the complication whenever related to the disease or even related to the medication. You need to sit with your patients and to give them a lots of information how to deal with the patients with diabetes as well. One of the most important items here in transformation is called population health management. It comes here with the patient-centric approach. In the past, the patient usually going to hospital to have a treatment. Transformations mean you need to deliver that treatment for your patient based on what their need. So active registration, what we had here in Riyadh Cluster 3, we built that having a little bit of view what the commonest 5 diseases that we need to deliver for our population. We found that type 2 diabetes, one of the most common diseases that we need to intervene. So I think all of us, we know about the model of care. This is the concept of the transformation in MOH all over. In the model of care, we're catching all the diseases we have. One of the most important here is the chronic care, and the diabetes is the most important initiative pathway we need to looking on it. So once we are talking about the management of diabetic patient and the model of care, so I'm catching the patient's journey life from once the patient starting from safe birth till to the last phase. For example, if the patient comes to you in your clinic, you need to having lifestyle modification. If your patient's having a planned care like diabetic food, safe birth, if a pregnant lady with the diabetes, urgent care, hyperglycemia, hypoglycemia, chronic care with the chronic complication related to the diabetes, whenever macro, micro, and at the end in the cancer patient with diabetes as well. What we did here in 154 PSCs, we put a target plan within the year. We tried to having screening of our population per years. We put around 20,000. We tried to catching them up. We screening them based on the clinical practice guidelines. We're reaching right now 13% to covering them. But the good news, we have information. If we need to deliver, we need to catch it. And this is the patient-centric approach. All the patients they enrolled in diabetes pathway, we put a plan that we need to reaching the satisfaction around 95%, although it's below of the target, but the good thing is it's going up and down, and we learn from patient experience per se. Here, the summary of transformation. If you would like to treat a group of patients, first of all, to having population identifications, health need assessment, risk stratification, and the end you're starting from the model of care, that 6 initiatives, with finally you thinking about what is the clinical outcome I have, what is the financial outcome, how I'm reaching the patient satisfaction as well. So in patient satisfaction, one of the most important, as I mentioned by other colleagues, the virtual care. So the virtual care, we're estimating the cost avoidance in our country. So among in 1 year, we saved 7.9 million because we reaching the patient satisfaction, and at the same time virtual care, we try to avoid overload about the outpatient clinic. Other important things, we put a rule that any single physician who's interested to treat diabetic patient, they need to be ruled with the service line. So the dyad of the service line and the concept of the service line comes here with assuring the quality and the productivity of the physicians, and at the same time minimizing the practice variation from physician to physician, implementing the clinical practice guidelines, and managing physicians with the hiring with a lot of training. And at the end, we're going to the financial prospectively as well. So here, that's we talk, scope of service, what you need to do, how many patients you need to have, what the types of the treatment you can deliver to them, and how you're going to implementing the plan, and how you put the focusing KPIs and monitoring your outcome whenever financially or clinically. And this is usually what we are doing here. Any single physician is interested to treating patient whenever specialized or non-specialized physician PSCs hospital, they need to be enrolled regarding the clinical activity, and we are doing supervision to them. We put already the strategic plan to what we need to target in 2023, 24. We are building the clinical practice guidelines, training activity, and manpower utilization as well. The last things, which comes here with the new perspective, it's called IPU, or Integrated Practice Unit. The Integrated Practice Units, and the beautiful of this, it comes here, you are taking the group of patients with the same condition, same complication, you rule of them in treatment with the one single approach. So why we need to put a patient with, or enroll patient with IPU? We are thinking about there is a lots of burden about the number of the waiting list. We have also a burden about the waiting time for next appointment. We have also the providers burnouts. We have also patient satisfaction usually comes low, and spending efficiency as well. And the role of the IPU and the beneficiary usually going to be giving the highly provide satisfaction, patient satisfaction, decreasing wasting time, and also decreasing the provider burnout. So, for example, in our cluster, we found that the average waiting time list in diabetic patients usually comes 35 to 90%. And so we picked up the people who presented with high-risk patients, such as highly microvascular complications, so HbA1c more than 10, or the people who presented with hypoglycemia.
2 minutes, Dr. Khalid. 2 minutes.
Sure. So this is the service pathway. What we are doing here, we put the patient as the diabetic patients. We're having the chronic nurses coordinators. We put the medical pathway from the physician from A to Z, and at the same time from the monitoring to controlling and additional service they can providing to them. And the earned value of this project, we identify and we close the gaps. We put the facilitated and enhancing with operating all the issue. And finally, it comes here with the quadruple aim. As I mentioned by previously and triple aim, the fourth one usually here is staff satisfaction, a lot of training, a lot of junior staff is coming here. They're training from the consultant. The more expert physicians, they comes here as well. And this is the diabetes manpower, how we are doing them, starting from the main workforce and main staff, and later on the supportive staff usually have the backup about. And this is the way how we are doing the pathway. Usually patients comes here from Maw'id or Ihalati, and we just to take them in, from BHCs particularly, and after the clinical coordinator to put in the cycle of IPU. And this is the SMART goal. We put targeting why we need our IPU to be implemented, what we have here, what we need to reaching after this project. Finally, the beautiful of IPU outcomes, usually it's giving a better decision because you are sharing your knowledge with the other expertise physicians. And at the same time, faster cycle of care, improving patient compliance, satisfaction, and you're going to have good utilization of your facilities and manpower. Thank you very much.
Thank you so much, Dr. Khalid, for your interesting presentation. Now we will go to Dr. Aline Abdul Karim. She will present nutritional complication post-bariatric surgery. Welcome, Dr. Aline.
Assalamu alaikum. I would like to thank everyone for your attendance, and I would like to thank the organization committee. We will talk about the nutritional
was the first Omnipod tubeless pump was launched. Then 2012, it was the Eros, the other version. Then in 2020, it was the launched for Omnipod Dash that we have this version now in Saudi Arabia and all over the world. For the future, Insulet always promised for innovative and improving in the product itself. So through the Omnipod system, Insulet provides simplicity and freedom to dictate the borders around the world. The word itself, podders, we call it about the patient who are using Omnipod, we call them podders. So for the future, inshallah, we promise about the new version Omnipod 5 or Horizon. It's a hyper-closed system. Okay, let's go take a benefit of the Omnipod Dash system. The first one is living your life uninterrupted, which is mean fewer injections, fewer daily interruptions, consistent hand-free, no need to touch or see the insertion of the needle. As you see here on the screen, one pod is versus 14 MDIs. 14 MDIs, that is the number of injections for 3 days. So we will replace all these 14s with one pod. Tubeless flexibility. Omnipod is a tubeless, which means a fewer part than the tubed insulin pumps. The pod, it's hold and deliver the insulin without any concern of a tube getting in a way. So as you see in the Omnipod Dash, it consists of two parts, the pod and the device. The black one is personal diabetes manager, we call it PDM. Freedom to move. Freedom to move, which means that there is, the patient can be wearing the pod any site he wants. So the same site injections, the abdomen, the arms, and the thighs, back and front, same for the adults and the children. So enable more frequent site rotation. Okay, Omnipod, it's very simple. It's take only 3 steps. Fill the pod, then apply the pod, then press start on the Omnipod Dash system. Very simple. Okay. For the features for the pod itself, it's very small and lightweight. For anyone who visit us in our booth and there and hold the pod, it's very small and very lightweight and can patch it on any site of injections. It's waterproof, tubeless, automated cannula insertion, no need for adapter or something to press on. Just patch it and press with the PDM start, it will insert it automatically. The reservoir inside the pod, it can be filled up to 200 units of insulin. The minimum is 85 and the maximum 200. 72 hours non-stop insulin, no need for disconnect, which is mean 72 hours for 3 days with extend 8 hours, so the patient have the flexibility if he is out, so can return back to change and put a new pod. Bluetooth wireless technology communicate between the pod and the PDM. The PDM, Personal Diabetes Manager, the features is start from 0 basal. 0 basal rates, it's very helpful especially for pedia, if they have like a honeymoon phase or they forgot to stop the long-acting like Tresiba and Lantus, so we can make like a basal program to start from a period of time from 0 until the insulin of the basal insulin from their body is gone, then it will start immediately for the actual program. Can set insulin to carb ratio 0.1 gram per unit of insulin increments. Also, it can be delivered 0.05 of insulin increments through the pod. This is the smallest insulin increments, which is very great for pedia. The pedia who need very, very tiny of insulin increments. Pod site tracker. Pod site tracker, this is a feature for the patient when they apply the pod, they can choose, I apply it on the left-handed. So next time when they change the pod and they wanted to put another one, like they remember them and change they put the another side. User-centric model and sleek designs. As you see, it's like a phone. it's a technology. Secure lockdown smartphone technology, Bluetooth wireless technology, communication between the pod and the PDM. I'll skip the video for the sake of time. Okay, the data behind the benefits. There is just a small data I'll share with you about the Omnipod. This one is the continuous insulin delivery. A prospective open-label study published in Diabetes Care measured the impact of short-term infusion set disconnect on a glucose level, which means Omnipod, it's waterproof. So when the patient wants to go to take a shower, to swim, diving, no need to remove the pod itself. No needed. They can go and take a shower, diving up to 7.6 meters, up to 1 hour, without any concern. We, as a paramedics, we guarantee a good adhesive, and the product can save with no, it will affect by the water because it's waterproof already. So that means this study is measured whenever the patient, they are using a tubed pump, when they want to go to shower, they need to remove the pump, so they go to take the shower. So this one, every minute, let's say if they take a shower for 10 minutes, so with every minute and they are taking the shower, they have to increasing their blood sugar with 1 milligram per 1 minute. So a 30 minutes interruption of basal insulin infusion resulted in significant glucose elevation, like 1 milligram per deciliter for each minute basal infusion was interrupted. They removed the pump. For the patch pump, this will not happen because the patient, they can go easily take a shower and doing whatever they want without any interruption. Okay, patient preferences for the Omnipod system has been observed. This is a retrospective UK study comparing long-term changes associated with different pump use in over 500 patients under routine care condition. This one, under care, the conclusion of this study, there were no significant differences as benefit and comparing different pumps about HbA1c or lowering hypoglycemia or something, but they see a significant preference of patient for continuous of using the pump over 3 years. Some of them, they are stop using the pump before 3 years and shifted to another pump, and some of them, they are continuous. Like you see, the Omnipod is the purple one. They are continuous even after the 3 months for using patient using for Omnipod. This is an online survey in US for over 1,200 Omnipod users about showing the improved of quality of life after using the Omnipod. So it shows about 4 perspectives: the perceived control and diabetes distress, overall well-being, and hypoglycemic safety. As you see the result here, for the hyperglycemic safety, it was improved by 51%, over well-being 54%, diabetes distress 70%, and over control is 73%. Last one, the satisfaction of the Omnipod. This is an online survey also, a patient that they are trust and satisfaction has also been highlighted in the survey about the Omnipod user in US. 95% said that they are trust the Omnipod system. 97% they recommend it to the others for using Omnipod. 87% they said that Omnipod system make their diabetes very easy. And that's our logo for the Omnipod. Last but not last thing, we provide Gloco. Gloco, it's a platform so the physician can follow up their patient about like an AGP, daily summary, and the devices setting, enable population tracking, and also the data about PDM itself. How many patients put carbs, how many patients the LPG readings, any hypos and hypers that the patient was entered by in the BG readings. Thank you so much.
Thank you. Now we have Dr. Fuad Maghrabi from Fitelair Company to present.
السلام عليكم دكتور خالد. السلام عليكم جميعا. Good afternoon. Akh Abdurrahman, I don't see my presentation on the screen, on my screen here. Should I connect the monitor again? Should I disconnect? It's not appearing here. لا هنا مش شايفها هنا. Okay, thank you, dear Abdurrahman. I would like to thank the organizers of this meeting, the scientific conference. Dear colleagues, I would like to thank the panel for leading this session, and also my colleagues who helped me perform this presentation. My name is Fouad Maghrabi. I'm a doctor. I'm in charge of developing healthcare services for the MENA region. And my presentation today is about value-based healthcare. It's an introduction to the topic after the nice presentation Dr. Khaled Al-Ghulais did. So it is just highlighting definitions and going through some practical examples and finishing and landing at some examples from a Saudi experience, showing some health economic data related to Saudi. So, first of all, my presentation will highlight, beginning by the healthcare context, some notions about what is value-based healthcare as per our understanding as a healthcare company, as a home healthcare company, adding to your puzzle of the patient card pathway some services that matter for patient to get in better health. Then I will go through some examples highlighting diabetes and experience on some data related to value-based healthcare applied to diabetes. And at the end of the day, or at the end of my presentation, I will summarize with the value proposition as a home healthcare provider. What could we add to the puzzle here in Saudi for increase or improve lives with patients living with diabetes? So, healthcare context, you know all that reimbursement systems today are focusing on volumes of care, volumes of money, the cost, and more than the value. This is the picture overall. The aging, the population all over the world is aging. We should focus more and more on the changing lifestyle and the increase of the healthcare expenditures linked mainly to the importance of the chronic disease, which is the main component in when we manage healthcare all over the world. It also applying to Saudi as the life expectation through Vision 2030 will expand, will be much longer, so we have to manage more and more patients with chronic disease. These patients, half them are living with a chronic disease. 20 to 40% of these healthcare expenditures are allocated to manage waste in the healthcare system. So there is, in the healthcare system today, a shift from fees for service to fees for value. But if it comes to Saudi, maybe we are between the fees for devices and fees for services, as services are improved today and will be reimbursed in the near future with the Vision 2030, with this transformation of the healthcare system. And in the near future, we have to go very fast to the fee for value. So what's the value? For sure, you know Michael Porter, who is a university professor, one of the main speakers about value-based healthcare as a methodologist. And so where we take the definition of the value-based healthcare, I would like to begin with this example by letting you vote. Unfortunately, I cannot see people outside this, connected outside this room vote, but I would like people here vote. If you had a serious problem, serious disease, would you go to the hospital A or hospital B? So we'll give you some information. Hospital A is carrying about 5,000 patients with this disease, similar to yours. Then hospital B is carrying about only 1,000 patients. Would you go to hospital A or B? This is a vote. So A. Why the A, please, doctor? You are a surgeon, so for sure you will tell me they are experienced. They know how to deal with the patient, right? Why 5,000 patients is more important than 1,000? Thank you. I 100% agree with you. So doctor is an expert, he's a surgeon, and he's telling us that the learning curve is depending on volume. That's correct. So I think if we add another parameter, maybe we can have a better look on what is the experience of these patients in hospital A or hospital B. So patients in 30% of the cases can face complication in hospital B, then in hospital A, then in hospital B, understood, the rate of complications is very low. So here, maybe you change your advice about the hospital B, even though they have low volumes. And Aziz can share a bit. Maybe if I tell you that about the medical economic model of for the payer. For hospital B, they ask for co-payment from the payer, even it is for cash patient, even it is for the insurance, the payer, who's the payer. So it will be the co-payment between the payer and the hospital. Then the second hospital is with a different model, proposing payment depending on success. And then you have a big difference between hospital A and hospital B. Now we ask you to vote for this comparison, and for sure, the balance changes, right? So thank you. This was the illustration.
2 minutes.
Yeah, sorry? 2 minutes only? Okay, you had to, I cannot perform. Can it be more, please? Because I have some examples at the end.
Same interesting presentation, and I like it. I like it from beginning. There is voting and something, but we have life limit to end the conference. Thank you.
Okay. So we'll be very quick to go through this thorough presentation. I prepared for 45 minutes, so I was briefed for 45 minutes. I want to bargain here, but I will go very fast. So one of the examples maybe you heard about is the Martini Clinic in Germany. And Martini Clinic is
caring about prostate cancer. So if I was a patient, I will Google it, and I will find some data about prognostic. And this prognostic for prostate cancer is 5 years expectation for survival. But if I'm a doctor, I would say maybe, yes, that's normal. People, when they face prostate cancer, is linked to elderly, to age, so maybe they will die from elderly before dying from metastasis. But this clinic is focusing on other outcomes. So out of the clinical outcomes, they're focusing on these complications, 1 year incontinence with patients, so then they improved a lot this outcome, and the severe erectile dysfunction in this man, and then they improved compared to the general status in Germany. So here, for sure, they are in the case of Hospital B, and they are excellent addressing outcomes that matter for patients. I will go very fast. So about these outcomes, I want to put these outcomes into this figure. The value in health and care should be the outcomes, or the weight of outcomes divided by the cost. And for sure, for talk about outcomes, we talk about some clinical indicators, okay? If it comes to respiratory diseases, about saturation, about apnea, hypopnea index for people experiencing sleep apnea. If we would like to put some KPIs for this, we will target the number of masks, the adherence to treatment. But if we want to focus on patient, we would add some other aspects or some other outcomes that are somnolence, mobility, autonomy, which are important for the patient. These are the PROM, the patient-reported outcomes or measurements, and some patient-reported experience measurement, like the experience with the care, the experience with the provider, the time to treatment, time to diagnosis. So I think that Dr. Lamia is here, the leader for this kind of measurements. I know that you are measuring the time before surgery, the waiting time for the patient all over the kingdom, and this is a first experience all over the kingdom, and we would be happy to participate in collaboration with the MOH by measuring the outcomes and improving lives in Saudi. So very fastly, the classification of these three outcomes can go through 3 tiers, from the most important to the hardest one, which is tier 1. Tier 1 is survival, degree of health versus recovery. The tier 2 is the time to recovery, the utility of care of treatment process, and the tier 3 is the sustainability of health recovery and long-term consequences of the therapy. So this goes bottom up from this to this. And maybe you know well the nice publication of the International Consortium of the Outcomes Measurement. Here you find the most important outcomes you should measure. It's regrouping 12 outcomes, categories, starting from clinical outcomes and including events. If it comes to diabetes, it is events of acute events and chronic complications. Then you have this circle with all these outcomes categories that should help drive the best outcomes that matter for your patients. This is what we are doing today, and what I want to show you. So we know the outcomes, okay? Then we develop our services, the services to help patients achieve a better health, okay? Then we measure our value for health for these patients. Then we dialogue with payers to value these services and to value these outcomes to get a payment at the end for these services improving lives. So the other component of the value-based healthcare is the cost, of course. Actually, we are shifting from the budget management, budget by hospital, by cluster, by department, to VBHC models, which is completely transforming the way we allocate budget or money to improve lives. Today, we are focusing on patient pathways, and maybe some patients will cost a lot to the system, and we want to reduce this number of patients. Then other patients will cost a normal range of cost we should afford. And here, there is a big difference in managing patients rather than managing the budget for the hospital or for the department. Sorry. Then we should not forget what matters here for this presentation. We are looking for improving value-based healthcare by improving the outcomes and reducing the cost. This is what I mean here, okay? It's the best scenario, improving what is up and reducing the cost to achieve these outcomes. Then, if I talk about diabetes very rapidly, a lot of publications, I will summarize rapidly. Diabetes is a burden for all over the world. It's a pandemic, you know. You see the increase of the prevalence of diabetes all over the world in the first one, it's not showing. So then the second one is showing Saudi prevalence. It's not a secret, okay? It's the top 5 or top 7 ranking, depending on the year. And then diabetes can cause chronic complications. It's not a secret. Also, chronic complications that are costing a lot. So this is what we should focus on, the patients with these complications. These complications are related with or highly correlated to the level of control in these patients. So if we consider the A1C, now we have models considering the time in range, the time in better health. Then the cost in Saudi is almost $15 billion, if I'm not mistaken. Diabetes is a cardiovascular disease and is causing a lot of complications, direct and indirect complications, and all this should be considered when we build a healthcare model. There is at international level one, as European countries are using the model of IQVIA taken from Stefan Rose, who is the expert in medical economics, a professor, and it's showing some cost-related indicators that should be taken into consideration when it comes to evaluating health from a beginning, from a baseline to end of an assessment. Then you have cost for every KPI, considering the European situation. But recently we had some publications in Saudi done by Muqdad in 2014, done by Al-Mutiri, and recently Al-Harbi presented what improvement in time and range should bring to the patients or to the healthcare system when we improve the time and range and the A1C in children living with diabetes. So we have Saudi models, we have some costs linked to the clinical parameters, yet we have to consider the costs of the other related costs and indirect costs. Rapidly compared to SMBG, if we consider, I have more slides to explain what I'm talking about when it comes to using the technology. Dr. Mohammed Al-Mahdi highlighted the experience from the King Fahd Medical City with patients using the closed loop system. You know, it's the cutting edge technology today in diabetes, certainly for a category of patients. Then you have CGM, the continuous glucose monitoring, that should address more than 300,000 patients in Saudi living with type 1 and with type 2 multi-daily injection or complex regimen. And a lot of evidence showing that when you compare CGM technology with finger pricking with the glucose meters, you are doing savings for the healthcare system by improving the A1C, so reducing the A1C, improving the time range, and of course, we can have a look on what we should compare to what is afforded by a system. It's always less than what we are willing to pay for a system. And I will finish with this. A lot of studies showing that hybrid closed-loop systems are better than patients using insulin pumps with sensors not connected to the insulin pump. So data is showing improvement in HbA1c, also improvement in time and range, and this is of course to reduce complications at the longer term. These studies are shorter than we can imagine. So in general, it's 1 year study. It's not showing the full picture, but if you consider the DCCT over 30 years, or the in type 1, or the UK PDS, you are talking about 15, 20, 25 years in type 1 and type 2 patients respectively. And here, the impact on complications is very frankly marked when the diabetes treatment is intensive at the beginning, and with the memory of this intensivity or this improvement of diabetes parameters. So for the key takeaways, I hope I respected the time. Some key takeaways: value-based healthcare is a transformation in the way we are managing the healthcare system or the healthcare expenditure. If we talk about budget, but here we are talking about outcomes that matters. So we are transforming or shifting from budget management into focusing on what matters for the patient, and focusing on where exactly patients are in need of support, in need of education, in need of investment we should make in their health. This is what I wanted to share with you. Thank you so much again, and thanks for all my team that is here with me. Thank you, and thank you for the panel.
Thank you so much. I want to thank our previous speaker in the two sessions before, Dr. Al-Mehdi, Dr. Glaise, and Dr. الصانع, and Dr. Sara, and Dr. Mustafa, and everybody. We want to close our conference for this second day. I want to thank you all, and the talk for Dr. Lamia and Dr. Abdullah Sehemi. Thank you.
المشاركين وجميع الزملاء، ويمكننا تأخرناكم شوي إلى وقت متأخر على غير الاتفاق، وأنا سعيد جدا بوجود الزملاء البروف صاعد فكف الآن. تفضل بروف.
يعني احنا ندور دائما المالتي ديسيبلينري، وفعلا حققها دكتور محمد غاصب، فيشكر على هذا الجهد. الله يجزاكم خير كلكم، شكرا جزيلا.
بارك الله وجودكم. استاذنا في
لا ابدا ابدا.
احنا نقول ضيفنا من الشرقيه. ايوه ضيفنا من الشرقيه، تفضل. لا خلاص هذه للمؤتمر ما هي للفضل. في ناس كثيرين كانوا يشتغلون طول الايام هذه، يمكن لنا 3 شهور شغالين في موضوع فقط اخراج المؤتمر بطريقه تليق بالزملاء والضيوف المشاركين. انا باسمي باسم